Assalamu alaikum, doctor. You can hear me well and you can see the screen. We can start. Yes, doctor.
Hear you.
Clear?
We can hear
Yeah, let us start. Inshallah, today we'll do the final revision for the MRCOG part 2, the one they are going for July exam. With all prayer, with all the best. We'll be here, Dr. Fath Ar-Rahman and Dr. HUSSNIA with you in this session. We'll highlight the most important part for exam, and we'll talk here for the one for the let's start first by the name of Allah, and we'll tell you for the one for the first time to go for this exam. In this exam, it is computer based, as you know. And in this exam, we have the single best answer. It will be 40% of the mark in each paper. And we have the extending matching question, the 60% of mark paper in each paper. This is the very important. And you ask in the group how to manage the time for the MRCBI, MRCOG. The time, it is very important, as you know, and we have the time, exam timetable, doctor. We have the first paper and the duration for the first paper, it will be 3 hours. It will be 180 minutes. And the number of question, we have 50 SBA question, and we have 50 extending matching question. And the time management candidate are responsible for their own time management, but the also recommended 70 minutes for SBA and when 10 minutes for MQ. And the MQ, it is very important. And there is break. It will be between this paper 1 and paper 2. And paper 2, doctor, also the duration, it will be 3 hours and it will be 180 minutes. And also for each paper in paper 2, it will be duration will include 50 SBA question and 50 extending matching question. And the time management also, we need you to concentrate more in the MQ and we take actually, it will take from you more time, it will be 110. And for the SBA, it will be around 70 minutes. And usually don't worry about the exam because most of the exam you can solve the problem for the single best answer. Single best answer, it will at all not be your problem. For the one study well, for the one prepare well, and I mentioned before, this exam, it is not easy, and usually nowadays it is more difficult. I will not scare you, but this is the real information, but Alhamdulillah, the one in the group, the one in the course, you prepare well, and now we have 10 days to go for this exam. Let us concentrate in the most important point here. And if you refresh your mind and from your practice, from what you read from with your friend and what you revise, and our recall, we mentioned the recall, it will help you a lot. If I am not, it will be around 30%, it will be from the recall and other, but sometimes the recall it will be change the question. The one he study well, he know if this question recall and it is changed, he will be oriented. And sometimes it will be 40 from the exam in the EMQ and SPA. And most of the single best answer, doctor, you can answer from the recall. For this reason, I mentioned, I am following you in the group, but I don't know the group now. Most of the people, they are not there, but I used to send for you the important point. Any updated guideline, we have the material group in the DR.FATH. I will any update, it is there. So I think you are all update and you will go for this exam. After the recall, the important here, the recent update guideline. And as we know, all of us, the most guideline it is update. Yes, doctor, you are with me here, yeah. The one is new for this exam, maybe they are no, but the one old like me and the other, they are doing this exam, they will be oriented. Because before the guideline, it will not update like this. Nowadays, you can see every other day or 1 week, one guideline update, one GTG update. This is a problem here. We have most of the guideline update before in 23, little guideline update. But if you start from 24, 25, 26, many guideline update, and especially 24 and especially 25, many guideline update. And any GTG update, it is must, you will go through it before your exam. like what if I mention by like intrauterine fetal death, it is guideline update, and we have the ovarian hyperstimulation, it is the guideline update, and I mentioned for you in the group, I'll highlight for you in the recall group which guideline update, and in the material it will go by sequence. The last one update you can see, and the last GTG update I think reduce fetal movement. It can expect it to come exam question. So doctor, my advice to you before the day of exam, study early and sleep early so you will be relaxed, because this exam actually it is not easy. If you see here 6 hours, maybe around 7 hours you will be there. And this when brainstorming exam, it will be really difficult for you. So whatever you start, it will be clear for you. Don't take the risk. Sleep the day before the exam and be relaxed and go to the exam. If you relax from you read, from you revise, from your practice, you will do this exam. The problem here, we mentioned many times to how to manage SBA. It is easy and you can do it and you can pass it. The problem when we come to the extending matching question. Extending matching question, doctor, the problem here, why? Because most of it, they can model, the question will not be direct from what you read. And sometimes most of it from the guideline, and most of it will be from your practice. If you are practice, you are gynecologist or you are obstetrician, you will solve this exam. Let us go through this one, doctor. We mentioned this one, the single best answer, it will be 40. Of the mark in each paper, and extending matching question will be 60% of mark in each paper. This we know, and we have here doctor for the first time to go for the exam. When let us listen to this video in the person view, they will tell you.
No, la viva no más fue.
Procedure to complete before testing. Your confirmation email will inform you how early to arrive for your appointment. The test administrator will confirm your appointment and begin. You will be asked to read and agree to the testing rules. Then we will check your identification. Many programs require 2 forms of ID. For example, driver's ID or credit. Requirements vary, so be sure to check the code for specific ID requirements. Next, the test administrator will ask you to sign your name on a digital signature pad and compare it to the signature on your ID. Depending on the you may be asked to scan your phone. Either use a near infrared light source similar to a TV remote to scan the veins in the phone. The information is converted to a digital tablet and used to prevent any
Ganon nangyari hindi ko mo.
process is simple, accurate, and never many out of something. Next, you take your photo, all personal data, including photo, fully translated, and stored with your test results. The next step is to store all your belongings in a locker or other secure area. Items like a watch, wallet, purse, phone, other suit, or any other personal effects. Doctor will check for personal items each time you enter the test room. You'll be asked to hold up your hair to show that no electronic device is present. Lift or tie or hood to show that nothing is computed. And pull up your sleeve. You'll request that you turn out your pockets, run your hands around the waistline, and down the front. Lastly, you will remove your glasses, place them on a desk for visual inspection. Once you've completed the admissions process, you'll be given an erasable notebook and displayed to your workstation in the test. When your exam contracts, you will be monitored by the proctor, your video recording. When you reach a scheduled break, if one is included in the exam, or if you need to take an unscheduled, simply raise your hand and the proctor will assist you. You need to show your ID or repeat the on base scan each time you leave and return to the when an exam is complete, raise your hand and the proctor will switch you out of the testing room. Depending on which exam you take, you may receive your story. Once you retrieve your personal items from a secure area, your testing experience is complete. Should you need accommodation, visit your program's page on pearsonview.com and click on accommodation. There, you'll find a deep and to request an application. All of us at Pearson View wish you a smooth and successful finish.
Yes, doctor. Yeah, this is the one. I think not all this process. Only your ID, and you will go there, and you will take your paper, your exam. They will give you the first paper. When the first paper is finished, and after that you can take break, and after that you'll start the second paper. And after when you finish the last question, you can revise. And some important because you will ask for the many the time. Most of the one they go for this exam before, or they will go for this exam for the first time. The time management, it is very important. And most of the time you will not finish. For this reason, I want you to concentrate. We'll start by what, doctor? We will start by the SPA, the first one. Answer the SPA. And after that, because you will struggle with the MQ. You want this one, not this one. But the MQ first, SPA, we will start by the MQ. We need to see this MQ how to manage, because I will not read, because they will give you some in many exam, maybe they will give you 15 or 20 option. In this 15 or 20 option, I will not see. I will see the heading of the question, and after that, I will decide which answer for this question. And after that, I will see the option. Like this one, you. And after that, when your first impression for this exam, your first answer, it will be the correct one. And if you have difficulty, don't flag all the question. If the question, the one you don't know, the flag the question and come back, because the time I tell you, you can. Sometimes you cannot finish. But if you manage like this, SBA first, MQ is the heading, answer the question first, and after that, go and see how you will do it. And inshallah, by the name of Allah, you can relax. And after relaxation, because if you will be tense also, you cannot do the exam. With all prayer, you will achieve your target, and you will finish this second part of our surgery. And here, because this Embrace UK, we are all here. We are all here to study for what, to saving life and improving the mother care. Yeah, we agree for this one. And really, believe me, when you will study this MRCOG, you will feel you are different, not like before. And in your hospital or in your trust, you feel you are a different person, because you follow, you have guideline, you will follow, and you have, if any problem, you have where you save guideline, you will revise. So it will be important. And this Embrace UK, it is updated in 2025. If you have little time, doctor goes through the heading and what they have in this new Embrace. We have here the leading cause of maternal death, now the blood clot, because the most important the VTE, and how to manage the VTE also in exam, it is very important. Yes, doctor. And the second one will be heart disease, cardiac disease, and the third it will be the COVID-19. And after that, the mental health condition, another exam question, and epilepsy, another exam question. For this reason, doctor, I want you to concentrate here the VTE, and in the VTE, usually it appears 3 or 4 questions.
Which one are you
You
voting?
agree? You
I am
agree
not.
with me,
I don't
doctor?
think
Share
this
with
is.
me, talk with me, so we'll do the exam together. We have the VTE. Who is there? Who is in the course? Doctor, yeah, you.
Guys, please mute your mic, guys.
Yes,
Guys,
But it just
mute
makes
your
sense
mic,
because,
guys.
that's
yeah, and we have the blood clot,
has
and
to
we
be,
mentioned
I don't
the
know,
VTE, the most important.
which
It will
one
come
you
3 or
want.
4 questions in the exam. And after that, the cardiac disease, we do
But
in the course,
I
and you will
want,
revise this one. Doctor, please mute your mic. I mute
EFF.
all. Yeah,
But
and after
obviously,
that,
I know EFF, so you will never
and
win.
Okay, Bess,
But
please
better
mute your
go.
mic.
I'll put it in.
Okay.
I know.
yes, doctor. And the second one will be the heart disease. And I tell you, the cardiac disease is very important. We have how many talk? Most of the heart disease, the material from the talk. And if we'll start from the myocardial infarction from 13 till the last one, valvular disease, it is very important. Now you can revise some record. And after that, the COVID-19, we have the last talk, this one, you can go through it. And the mental health condition, it is very important, and it can come exam question. because we have the mental health. This we depend mainly on the NICE guideline and mental health. We have one talk, and they are repeat the same question and from the record. Don't be worried about this one. And epilepsy and stroke very important. Stroke we have the talk, and epilepsy we have talk, and we have the GTG. All very important. And epilepsy it is very important, like hypertension, like diabetes in maternal medicine. Epilepsy it will be in the top. You will know about the contraception. You will know how to treat the patient. All this one in the maternal medicine, it will be your focus here for this exam, doctor. And then we will start by labor module, and I put for you in the recall group the module all the time. I want you to start, doctor. The one they are going for January, and the one they are remaining only 10 days. The module also for revision, it is very important because if I will follow module, I put now the module in front of me in the group most of the time. If I want to revise, if I want to do anything, I will see in the module which is done and which is not done, because the exam also depend nowadays in the module. They will start from the top, and the labor module, labor and delivery, it will be in the top. And usually we have 4 and 5 questions from the labor module about how to follow the patient, about how to deliver the patient, the CTG, any contraindication, any problem. They will give you most of the time. They will give you 5 questions from the labor module. Let us start, doctor, by labor, and let us go through the session. Who will share with me? Who will come here? The first one. Let us start the question. Yes, doctor.
Okay, should I read?
Yeah. Your name, doctor?
Sana.
Yeah, Dr. Sana, start. And let us go through the labor. How we'll take it. Yes.
A nulliparous woman at 40 plus 2 weeks is in established labor. She has regular contraction and she is 5 cm dilated. 4 hours later, vaginal examination shows cervical dilation of 6 centimeter. The fetal heart rate is normal, membranes are intact, and maternal observation are normal. What is the most appropriate next step?
Try in the exam, Dr. Sana, and all, you will analyze the question. Before I tell you, when we did this exam, we have the paper, not the computer. Now it is computer. You can see. I highlight for you the most important part. Then in the exam, they will give you paper and they will give you the ball pen. You can write whatever you want in your paper in front of you. Here, your patient, Dr. Sana, she is nulliparous and she is 40 weeks plus 2 days, and she's 5 centimeter dilated, and after 4 hours in the partogram, the patient she is 6 centimeter. Is that normal? The patient she will be dilated only from 5 to 6, 1 centimeter, or we have some problem here we need to manage or interfere? I tell you, the exam, it will come the MQ. I will not read all the option. I will answer. If I have from 5 centimeter to 6 centimeter in 4 hours, does that mean what I have problem here and how I will manage this problem?
There is no option of the artificial ARM.
Yeah, first you will say here, Dr. Sana, you have suspicious delay. Yeah, and after that, when you will do, if you have suspected delay in the first stage of labor, what you will do? You will, what is the action? It will be done here, and after that you will see. Because the partogram, yeah.
We have to go for repeat vaginal examination in 2 hours.
Yes, correct. You repeat the vaginal examination 2 hours because you have only suspicious delay. You are not confirmed the delay. So examine the patient in 2 hours and see. And after 2 hours, reach this one Dr. Sana, delay in the first stage of labor, because we have delay in the first stage of labor and we have delay in the second stage of labor. Tell me if you have delay. Read this one from your guidance from NICE.
Okay. If delay in the established first stage is suspected, taking the following into account: PRT, cervical dilation, and rate of change of the cervix, uterine contraction, state and position of the presenting pod. Offer the woman support, hydration, appropriate and effective pain relief according to amended 2023 and 2007. If delay in the established first stage is suspected, assess all aspects of progress in the labor when diagnosis delay, including cervical dilation of the less than 2 cm in 4 hours for first labor, cervical dilation of less than 2 cm in 4 hours, or slowing in the progress of labor for second or subsequent labors, descent or rotation of the baby's head, changes in the strength and duration and frequency of the uterine contraction, amended
Yeah.
to 2000.
Yeah. Yes, Dr. Sana, here, if you have a suspected delay for the patient nulliparous or the patient for the second time or subsequent labor, that means you have the patient multiparous here and you have the patient nulliparous here. If you have less than 2 centimeters, that you have suspected delay. In suspected delay, here is this one. Let us see.
If delay in the established first stage of labor is suspected, discuss the findings, see recommendation and the options available with the woman, and support her decision. Amended to 2023, offer all women with a delay in the established first stage of labor support and effective pain relief. 2007, advise all women with suspected delay in the established first stage of labor to have the vaginal examination 2 hours later. Already we have selected this
Yeah. You
answer and
select this one. Yeah. And diagnosed delay,
diagnosed
progress is
delay
less than 1
if
centimeter.
progress is less than 1 centimeter. 2007, if delay is established in first stage of labor is diagnosed, consider amniotomy for all women with intact membrane. After explanation of the procedure, and advise that it will shorten labor by about an hour and may increase the strength and pain of contraction. Amended 2023, do not advise transfer to obstetric-led care for amniotomy alone. Okay.
Yeah. Now you understand, Dr. Sana, all here first time you have suspected delay. We examine the patient in 2 hours. Most of the doctors they want to do a amniotomy first. No, because only you have suspicions of delay. Do examination in 2 hours and after see. And after 2 hours, do amniotomy after all this counseling and tell the patient and bear relief and consider amniotomy. Explain to the patient, consider that mean explain to the patient. If the patient agree, do amniotomy. And after that, see what will happen. Yeah. Yes, Tarsana?
After amniotomy, advise the woman to have repeat vaginal examination 2 hours later. Amended 2023, if there is no progress 2 hours after the amniotomy, diagnose delay and transfer the woman to OLC. Follow the general principles for transfer of care described in section 1.5. Take into account that the presence of another risk factor in addition to delay may increase the urgency of transfer. Amended 2023, for all women with confirmed delay and established first stage of labor, an obstetrician should offer full assessment. Okay, the obstetric review should include abdominal palpation and vaginal examination, constitution of oxytocin. Amended 2023.
Yeah, yes, Dr. Sanan, all because here for all women to confirm till an established first stage and obstetric should offer full assessment because you have some problem. Why this patient she is not progress, especially if the patient multivirus. And the obstetric review should include abdominal examination, vaginal examination, and consideration of oxytocin. Maybe the patient malposition, malpresentation, and maybe the patient she had no sufficient contraction. After all your full assessment, doctor, then what you will do? This is yeah.
Discuss the use of oxytocin with the woman and make a decision with her about its use. Explain that her choice to stop or restart the oxytocin will be supported. Using oxytocin after spontaneous and ARM will bring forward the time of birth but will not influence the mode of birth or neonatal outcomes. Oxytocin will increase the frequency and strength of contraction, and that its use will mean that her contractions and her baby's heartbeat will be monitored continuously using CTG. See NICE guideline on fetal
That
monitoring.
means, Torasana, if you will start oxytocin, you will consider to will be continuous CTG because you will know. Now you augment the patient by oxytocin. So here consider continuous CTG. Yes. Then.
Oxytocin can cause hyperstimulation of uterus, which may increase the chance of transient fetal hypoxia. If hyperstimulation occurs, the dose will be reduced or stopped. Amended 2023. Offer the woman an epidural before oxytocin is started, or if she requests it later. Amended 2023.
Yeah, because oxytocin will be more pain. Better before you will start, offer the patient to take the epidural. This is the most important part here. Yeah, correct. Now you clear this part and can come exam questions. The delay, confirm delay, and what you will do. And after oxytocin and after all this one, if the patient she had confirmed delay in the second stage of labor, and you did first you examine, and after that you did amniotomy, and after that you examine the patient after 2 hours. And after that, you ask the patient consideration for oxytocin if she agree. And when you will start the oxytocin, examine the patient after 4 hours. And after 4 hours, see if the patient progress, good and fine. If the patient no progress, that means the patient she had some problem you want to manage. Better you will consider cesarean section. After full assessment, you can see what is the problem to this patient. Yeah. Then second question, Persana.
A primary gravida with an epidural is fully dilated and has been actively pushing for 1 hour. The fetal heart is reassuring, the head is descending slowly, and maternal observations are normal. Encourage continuing pushing.
Yeah, what is the most appropriate next step? This is your question here, Victoria, Sana, and all. We have first, if I have, I will go to the patient in labor. The first thing I will determine, Victoria, Sana, the patient, she is multiparous, nulliparous, or she is prime, because it will be different. And after that, the second point, it will be determined the patient, she is under epidural, or the patient, she had no epidural. Because with epidural, we can add more hour. If CTG is good and the patient, she is fine. Yeah, our patient here, she is primary, and epidural, that mean her hour, it will be more. And CTGs, I tell you, good and everything is fine. Then what you will do? And only how many hours she has been actively pushing for 1 hour. That means she is in the active second stage because in the epidural we add 1 more hour in the passive. And now our patient only she had pushing for 1 hour in the active second stage and under epidural. And then what from this option? What do you think it will be the best and correct answer? Doctor in the chat, you can answer.
D.
Reassess progress, contraction, and maternal fetal well-being. They tell you here everything is good. That means they want you to add what? If the patient she had epidural, you want, that's you want to hear. She is pushing for only 1 hour. You will encourage her to continue pushing. Yeah, and support the patient. Yeah.
C.
Yeah.
Encourage pushing. Okay,
Yeah.
D.
Yeah, reassess progress, contraction, and maternal fetal well-being. Yeah, this is when it will be correct. And support to the patient if she had epidural and let her to take her time. If she is nulliparous or she had multiparous. Multiparous, she had less hour. Nulliparous, she had more hour. The prime gravid. And here they tell me the duration of the active second stage of labor for nulliparous woman without an epidural. Birth would be expected to take place within 3 hours of the start of active second. That means if the patient sees 3 hours, I expect this patient to be delivered. For multiparous woman with an epidural, within 2 hours of start active pushing. Remember, we are adding 1 hour in the epidural to the passive. That means it will be for, if we see for the primary gravida, 3 hours, and if we see for multiparous, 2 hours, the patient she will deliver. So if the patient she is epidural, it will be more hour because you will add one passive in this two, and if you have multiparous 2 and 2, it will be 4 for the primary breast. And this is the one I want to tell you about. Read this one. So in epidural, how many hours you want? So after that, you will interfere if the CTG is fine and the patient is fine. Dictora, Sana. For nulliparous with an epidural.
Okay, for a nulliparous woman, with an epidural, birth would be expected to take place within 3 hours of the start of the active second stage in most women. But be aware that these women may have had a passive stage of up to 2 hours after full dilation before commencing active pushing. After 1 hour of active pushing, reassess the clinical picture, including progress, contraction, and maternal and fetal well-being that we have selected the answer. If there are signs of progress in terms of rotation or descent of the presenting part, encourage the woman to continue pushing. If there are no signs of progress, offer vaginal examination and consider amniotomy. If the membranes are intact, if there is still no progress, diagnose delay and escalate for senior review. If birth is not imminent after 2 hours of the pushing, or refer the woman for a senior review and decision on place and mode of the birth. Amended 2023.
Yeah. That means, Dr. Sana, because our patient here, Nalibras or primary gravid, we give her 2 hours in the passive and 2 hours in active. And after all this, when if the patient deliver, you need to review the decision and place a mode of care. Maybe you transfer this patient, if not. So in the Nalibras here, you can give the patient 4 hours. If all this normal, the progress, the contraction, and maternal fetal well-being, it is okay. But if you feel any suspicious delay, not like the first stage of labor. The first stage of labor, I will wait 2 hours, and after that, I will do a mini-tom. Here, I will examine the patient after 1 hour. After this 1 hour, if the patient there is delay or I feel the progress not good, I will do the mini-tom. And after that, I will decide. Yeah? And then
Okay.
for multiparous with an
For
epidural.
multiparous woman,
Hmm.
for multiparous woman with an epidural, birth would be expected to take place within 2 hours of the start of the active second stage in most women. But be aware that these women may have had a passage stage of up to 1 hour after full dilation before commencing active pushing. After 30 minutes of active pushing, reassess clinical picture, including progress, contraction, maternal and fetal well-being. If there are signs of progress in system of rotation or descent of the presenting part, encourage the woman to continue pushing. If there are no signs of progress of vaginal examination, and consider amniotomy. If the membranes are intact, if there is still no progress, diagnose delay and escalate for senior review. If birth is not imminent after 1 hour of pushing, refer the woman for a senior review and decision on place and mode of birth amended 2023.
Yeah. This is now it is clear. In the nulliparous woman, I will examine the patient after 1 hour, and after that, I can decide. And in the multiparous woman, I will assess the patient after 30 minutes, and after that, I can decide. For the oxytocin, for the nulliparous woman, you can start if you feel the contraction not sufficient, the patient she is not contracting well, you can add. For multiparous, if she is not progress well, because usually we expect the multiparous woman to progress well, unless she had malpresentation or malposition or some problem. For this reason, need to full assessment. And after that, if the patient she had no regular contraction, you can start oxytocin. Yeah. Then, personal.
A woman in established labor requests an epidural for pain relief. She is an obstetric unit. She has been counseled about benefits and risks and still wishes to proceed. What is the most appropriate management?
Epidural, what she want? She want to proceed for the epidural. You tell her the pros and cons and the risk, and maybe it will be delay and risk for instrumental, and still she want. What you will do? Which one will be better?
See, support regional analgesia.
Yeah. Yes, correct. Yes, you will support her. Support regional anesthesia after counseling about the benefit and risk. After you explain to her everything, support her. And we have, I will tell this session, doctor, be with me. The most important part I will highlight because we have pain relief in labor. Or if the patient she came at any time with pain, this is the most important. I post for you in the group all the pain relief. And we have here a nice recommendation for if the patient in labor, woman in labor will be supporting the woman choice. We will give her all the option and let her choose because we have many options for pain relief during labor. We have the non-pharmacological and inhalation analgesia. And after that, you will care throughout labor. You will see the patient and support her. And after that, we have intravenous intramuscular opioids. Some patients will tell you, doctor, yes, I want injection. I am not want epidural. Or my experience in the previous delivery with epidural not good. And after that, if the patient she choose regional analgesia, it will be epidural. It will be provided by the information, establishment and maintenance and care and observe the patient. If this for the other, because sometimes if they will start the main question in the exam, they will be, if you remember, we have spondylitis, they will tell, remember that in the first trimester what I will give, in the second trimester what I will give, in the third trimester what I will give. I remember non-steroidal, it will be not given after 28 of 30 days. I remember in the first trimester, if they will give you the paracetamol, it will be okay. If they tell you after cesarean section, better you will give step 3, strong opioid. After delivery, if you give this one rectal Non-steroid, it will be better. Another exam question, they tell you the patient she is vomit after this one. That means from severe pain, you can give morphine. And remember the sickle cell disease, you cannot give penicillin and you can give morphine. All this one and anything till the exam day, we have all the material, doctor. If don't hesitate to ask. If you want anything, ask me. Sometime I'll be in duty or on call, I cannot post for you. If you want anything, it will be posted. No worry about this one. Yeah. Mhm.
Okay.
Remember,
27
now the labor question, the second one, the pain question. This one, the pain question, repeated exam question came as EMTU. This is, yeah, I am writing your exam till we'll finish the paper. زين دكتور سنة.
Okay.
Mm.
Bismillahirrahmanirrahim. A 27-year-old primary gravida at 40 plus 1 week in established labor on the obstetric unit. She is 6 cm dilated. CTG shows baseline fetal heart rate 150 beats per minute, variability 5 to 10 beats per minute, deceleration, variable deceleration with over 50% of contraction for last 30 minutes. Acceleration absent, contraction 4 in 10 minutes. Maternal observation are normal, Liker is clear, and there is no vaginal bleeding. What is the most appropriate management?
Mhm. Because in interpartum, we are afraid from the vaginal bleeding and we are afraid from the sick meconium. Or if the patient she had any risk factor, like the patient she is intrauterine growth retardation. And after that, see the scenario of the question. The patient she had variable deceleration with over 50 minutes of the contraction. That this is more. If for the last 30 minutes, for the 30 minutes contraction, 4 in 10, it is okay. In the exam, we will analyze your question like this. Maternal observations, the vital signs, the liker, all it is okay. Then how you will manage this patient? Mhm.
To continue CPD,
Mhm.
perform full clinical assessment of mother and fetal well-being, correct reversible causes, and review regularly.
Yeah. Correct the reversible causes because if you have any problem, we mention in this guideline, we are, if you remember before, we are giving oxygen if the patient she had CTG. Now they remove the oxygen. We have no oxygen unless for the maternal issue. The other thing, if the patient she is not she's hypotensive, we will do correction for the hypotension. We'll put the patient in the left lateral position, and if the patient she had any risk, it will be addressed. And regularly monitor the patient. If improve, good and fine, because here suspicious CTG, there is one reassuring feature. Nice recommend assess the whole clinical picture, checking for reversible cause. It will be corrected. It will be continuous CTG monitoring and reviewing the trace regularly, rather than immediate delivery if there is no acute fetal compromise. But if I have like Brady not recover or I have any like cord prolapse, any problem, that time I will go for cesarean section. It will be according to the category 1 or 2 or 3. Yeah. And here the fetal heart, it will be white, amber, red. This one we know. I will keep in the session. And we have this one deceleration. And in the variable deceleration, you remember this one concerning character, because in the exam sometimes they will give you the tracing like the previous one. It will be provide and they will tell you in the scenario of the question this tracing for how long. Sometimes they will tell you 30 minutes, 40 minutes, 50 minutes, and after that you can address the question and answer. And this one, it will be concerning feature if lasting more than 60 or reduce variability within the deceleration or failure or slow to return to the baseline or loss of previous present shouldering. Before I have shouldering, now the CTG become more bad. For this reason, I need to consider. And after that, your categorization for the CTG, we have the normal, we have the suspicious, we have the pathological, and you know how to treat the patient if she had abnormal CTG. Yeah.
A 32-year-old woman in her first labor is 8 cm dilated. She is receiving oxytocin for slow progress. CTG shows baseline fetal heart rate 170 beats per minute, variability 3 beats per minute for 50 minutes, deceleration, repetitive late deceleration for 45 minutes, contraction 5 in 10 minutes, maternal temperature is 37.8 degrees centigrade, Liker is meconium stent.
Here all problem, yeah. The variability is less, and the fetal heart rate it is stack, and we have the maternal temperature also start to be unlike arrhythmia. All the risk here, and the patient is 8 centimeter dilated in the first stage of labor. If in the second stage of labor, usually if the head down, like 0 and out, we can deliver the patient by instrumental delivery. And they like, doctor, in this RCG exam, they like instrumental delivery more than cesarean section. You will try your best. Unless they tell you the CTG very bad or the head is very high, 0 and above, this is the one I will not use instrumental. And if it is high, we know we'll go to the theater, we'll try there, because the failure rate, it will be very high. So our patient here, everything it is not good, and the patient, she is still 8 centimeters. Then what to
So
do?
we have to do the maternal urgent obstetric review, intrauterine resuscitation, and expedite birth if no rapid improvement.
Yeah, you need to, it is correct, because you want to deliver this patient. Yeah, and intrauterine, you will start
Urgent
everything,
obstetric.
and you will inform your consultant and the theater and everything. If improves, okay. If not improve, you will expedite the because this patient, the CTG is not good. And here we have decreased variability and we have tachycardia. In the exam question, they will give you tracing, and in the scenarios, they will tell you for how long, and they will tell you if the patient she had any risk when you will start. So you can manage this one. Be careful, read the question first, and after that, try to see what is the answer, and after that, see the option. Yes.
A 29-year-old primary gravida at 40 plus 3 week is fully dilated and has been actively pushing for 2 hours. The fetal heart rate is reassuring. On examination, the cervix is fully dilated, membranes are ruptured, and the fetal head is occipito interior at the +2 station with the minimal capat and molding. The pelvis is clinically adequate, the bladder is empty, and the woman gives verbal consent. What is the most appropriate management? Okay.
Mhm. Actively pushing for 2 hours. And the patient first, I will see the primary gravid. I'm pushing for 2 hours. And after that, surface fully dilated, membrane rupture. Yeah, if the membrane not rupture, we mentioned first we'll do the myotomy. The fetal head exhibit anterior. That means good sign. And the head is +2. And I want to deliver this patient. What I will do?
Instrumental vaginal delivery,
Yeah.
rotational forceps birth catheter,
Which option you feel?
RD.
The membrane rupture and the head exhibit anterior, and it is +2. You need any rotation here, or it is
Non-rotational.
okay? Non-rotational.
Non-rotational.
Yeah, and it will
Yeah.
be, we mentioned, if you have any problem, you want to deliver the patient, and the head is down, deliver the patient in the labor room. And if you have any problem, you feel this patient she will not deliver the patient in the theater, because he will compare to the cesarean if the patient not deliver. Here, the position is non-rotational ventus in the labor room. And if you have bad CTG and head down, also try to deliver in the labor room. And we'll deliver the patient in the theater if the head high and the CTG abnormal, because we convert. And the indication for performing assisted can be maternal, can be fetal, can be prophylactic shortening in the second stage of labor if we have maternal intracranial or the patient is hypertensive or cardiac disease. If you remember, we have one exam question. They will tell you the patient class 3 or 4. Usually, if the patient she will go for elective cesarean section, it will be better. But if the patient she came with once labor in the second stage of labor, you can help the patient by forceps. Yeah, and this is the type of forceps. We have non-rotational, and we have low cavity, and after that we have the Wrigley for outlet, or we have the Killand for the rotation. Yes, Dr. Sana.
A 31-year-old, a 31-year-old nulliparous woman at 41 week has been actively pushing for 2 hours with an epidural. The CTG shows recurrent variable deceleration. On vaginal examination, the cervix is fully dilated, fetal head is at 0 to +1 station, occipital transverse with moderate caput and molding. The obstetrician is uncertain that assisted vaginal birth will be successful. C-section may be required. If attempt fails, what is the most appropriate management? Okay.
Mm-hmm.
Show
It will
us the
be,
options.
yeah,
Trial
yeah,
of instrumental.
will be from the previous option. Yeah.
Okay, trial of instrumental delivery in the
In the
theater.
theater, yeah, because in the theater, because need this transfers, I think, yeah. So better it will be in the theater because need rotation. Yeah, and this is the one we mentioned. Yes, correct, Dr. Sana. Yeah, this case, trial of assisted vaginal birth in the theater, the head is with cavity, malposition, and there is moderate capital molding, and the success less certain. So I will go for theater. If not come, so you will go. And here, what time you will deliver the patient in the theater? Consider trial in the theater if you have head 1/5 palpable abdominally, or if you had the head is mid pelvis, or rotation required, or fetal suspicion of CBD. This is the time you will go for the theater. Other, you can deliver the patient in the labor room. Yeah, correct.
Do your old woman with one previous lower segment C-section is in spontaneous labor, attempted VBAC, she is 7 cm dilated. Suddenly, she develops severe abdominal pain between the contraction, maternal tachycardia, fresh vaginal bleed, and prolonged fetal bradycardia on CTG. What is the most appropriate management?
Typical scenario. Yeah. The
Yeah.
patient, yeah, previous lower segment cesarean section, they tell you.
Because maybe she's in rupture.
Yeah, it is look like rupture because suddenly develop a severe abdominal pain between the contraction, and after that maternal tachycardia, and baby CTG will be ready, and you have bleeding, and after that sometimes the presenting part in your hands, the presenting part it will be high. So this is a feature of rupture uterus, because you will be very careful if you have the patient she will deliver after VBAC, vaginal birth after cesarean section. And we have another recall question, doctor, if you remember in the VBAC, if the patient she start to be regularly contracted, it is very important it will be continuous CTG for this reason. If CTG become ready, so you will notice and will see the blood. So I think in July 21, they asked of VBAC, it will be continuous. Before she had continuous contractions, that the patient she can be interrupted or cannot be in the continuous monitoring. We have procedure aspect of cesarean section, classification of urgency of cesarean, this we know. Because in the exam, they can ask you if we have category 1, category 2, category 3, category 4. We have category, this if we have crash, this we know, crash the cesarean section, maybe it will be compromised. If we have maternal fetal compromise, but it is not immediately life-threatening. Most of you are confusing when I will answer the recall. They are confusing most of the patient like sometimes the patient fetal compromise, but not immediately life-threatening, you will go for category 2. Category 1, if you have immediate threat to the life of the woman or fetus. Try to differentiate, because I feel my candidate sometimes it is the answer it will be 2, they will answer 1. This is the crisis. If you have like placenta, previous patient bleeding, if you cannot go in 1 minute and deliver the baby, it will be affected. If you have maternal and baby, it will be affected, life-threatening, category 1. If it will be maternal fetal, which is not immediately life, it is life-threatening. There is some problem, but not this one, it will be category 2. Category 3, maternal, but need early birth, like you have patient you want to deliver. Category 4, like when you bring the patient for elective. And this is a feature associated with the uterine rupture. They will give you abnormal severe pain, abnormal bleeding, hematuria, cessation of previously uterine, maternal tachycardia, hypotension, and fainting. Yes, this is a sign of uterine rupture. Yes, Doctora Sena, carry on.
A 29-year-old woman at 31 plus 4-week present with a sudden gush of vaginal fluid, speculum examination confirmed pooling of the liquor. She's apyrexial and has no uterine tenderness, no contraction, and fetal heart rate is normal. What is the most appropriate management?
That means preterm premature rupture of membrane. From this one, if you have preterm premature 31 plus 4, how you will manage the patient?
Expectant care, ma'am.
Yeah, it will be expectant care. First, you will do investigation. You will give the patient steroid because she's still 31, and you will give antibiotic, and will come the patient. She will come back for follow up. Any problem, you will tell the patient. If you have abdominal pain, if you have fever, if you have any suspicious, you will deliver the patient. And remember also in the prom, usually we can extend till 34 weeks if the patient. Usually till 37 weeks if the patient accept. If not accept, it will be till 34 weeks. And after that, if the patient she had PBS positive and with prom, usually try to deliver the patient after 34 weeks. Any infection better after 34 weeks. No infection we can reach till 37 weeks. Yeah, correct. Person.
A 29-year-old woman present with mild vaginal bleeding at 5 plus 4-week gestation. She is hemodynamically stable and no abdominal tenderness. Transvaginal ultrasound show no intrauterine pregnancy and no adnexal mass. The uterine UPT is positive. What is the most appropriate next step?
What is the case here? No intrauterine, no extrauterine, and the patient she is pregnant and gestational age and mild bleeding, no problem. And the patient she is in early pregnancy, she's 5 weeks plus 4 days. Then what I will do if I have and what it will be diagnosed here if you have pregnancy, not intra, not extra. Yes, doctor. What will be?
We have to repeat beta STG.
Yeah, because you have here pregnancy of unknown location. If patient is stable, let her come after 48 hours and repeat. And the pregnancy of unknown location, it is not diagnosed, but temporary classification assigned to woman until definite diagnosis is made. And the number of ectopic pregnancy in woman classifies having pregnancy of unknown location vary in rate and range from 7 to over 30 and have been reported. This ectopic pregnancy rate reflects the quality of ultrasonography and patient population and department. That means it is pregnancy. You will need to follow the patient like here the NICE recommend measuring serum HCG and repeating approximately 48 hours later to guide further management while advising the woman to return urgently if symptoms worsen because it can be ectopic pregnancy and later maybe can fail pregnancy. Anything can be if you have pregnancy of unknown location and this is the one we will follow. Yeah. So you need to bring your patient in 2 days and do the beta HCG and after that you can decide because the patient they not tell you the patient she is in pain, she has no problem, only mild bleeding is fine. Yeah.
A 32-year-old woman. A 32-year-old woman attend the early pregnancy unit at 7 weeks by dates. The TVS shows an intrauterine gestational sac with an embryo measuring 5 mm CRL. No fetal heartbeat is seen. She has minimal spotting and no pain. What is the most appropriate next step? Okay.
In 7 weeks she is and crown rumbling is less than 7, that means 5 millimeter. And they did this one by transvaginal ultrasound because if done.
Repeat TVS.
Yeah.
TVS A.
Yeah, repeat the phase in 7 days because it is 5 millimeters. You cannot decide now. It is less than 7. We have the cut less than 7 and we have the cut 25 of the extensional sac. So less than 5 and the patient she is fine. I will ask her by transvaginal it can be 7 days and by transabdominal it can be in 2 weeks. She will come back to you. Yeah, correct.
Okay. A 24-year-old woman at 9-week gestation present with persistent vomiting. She has already tried oral antiemetics but cannot keep tablets or fluid down. She has ketonuria, tachycardia, 6% weight loss from her booking weight. What is the most appropriate management? Okay.
This from important, doctor.
She should need admission. She should need admission.
Yeah, need to be admit. This guideline, don't forget to revise all the important because come many time, they will not miss this guideline in the exam. They like the patient you will treat the patient in the community, or you will treat the patient in the daycare, or you will patient she need indication. Here she had many indication. Now from the update guidelines, they remove the ketonuria. It is not important like before. But if the patient lose 6% of her weight, this is the indication. And if the patient she had persisting vomiting, like this, the patient will be treated in the daycare. If the patient not improving, it will be admitted. And they will give you all this one, and they will come, so they will guide you. The patient in the daycare, it will not be medic, so it will be in the inpatient management. And we have the red flag. If the patient as a score and she had any complication or inability to tolerate oral intake and you give her in the daycare and she is not responding, or if the patient she is unresponsive to outpatient management, that means the daycare, or the patient she had clinical dehydration with weight loss more than 5, confirmed or suspected comorbidity. This is the one came in the exam before. I remember in the one recall they give you the patient she had UTI and she want to take the oral medication, she cannot, so it will be admitted. Comorbidity or unable to take medication, example like epilepsy, HIV, hypoadrenalism, psychiatric disorder, concern regarding the mental health. All this one to be admitted. Remember this one, red flag is any from this one, and they can ask you about the medication. Also remember to revise this one before you go. Yeah, is the
A 34-year-old woman. A 34-year-old woman is referred after 3 consecutive first trimester miscarriages. She has no living children. there is no history of ectopic pregnancy or molar pregnancy, which investigation is most appropriate? Antiphospholipid antibodies, because 3 consecutive.
Yeah. We'll start by antiphospholipid antibody. Remember, this recurrent miscarriage is very important because the GTG is update and they like. They will bring 1 or 2 questions from this one. So if the patient in the first one, it will be the antiphospholipid. We have the TOG update, I think, in the same year. And your recommendation, it will be from the GTG, Dr. Sanan. Yes, correct.
Okay, a 30-year-old woman with previous gravis disease treated with the radioiodine is now 12-week pregnant and euthyroid on levothyroxine. Her blood tests show positive TSH receptor antibodies. What is the most appropriate follow-up? What is the most appropriate?
Mm. She had grave disease before, but treated by the radioiodine. Now the patient 12-week pregnant, and now she's euthyroid, but on treatment. And the patient, she had TSH receptor antibody. You need to follow this receptor because she's fine now. She's on her treatment, and the patient 12-week. You need to do some anything here, or it is okay because the patient is fine.
No action.
Not to repeat.
Sorry.
Antibody?
Repeat. Thyroid antibody.
Yeah, you will repeat. You will repeat. And this is the one I will leave for you here. You will raise this one because maybe they will ask you what time to be the repeat if you have the antibody. Yeah.
A
So,
29-year-old woman books at 10 weeks gestation. In her previous pregnancy, she had gestation diabetes controlled by diet. Her current BMI is 27 kg per square m. What is the most appropriate screening plan?
طيب, she had in her previous pregnancy, she is GDM. And now she come to you 10 week for booking. What he will do here?
OGTT on booking.
Yeah, so OGTT, yes, correct. And this is the one. Assess the risk of gestational diabetes using the risk factor in healthy population. So at the booking appointment, check for the following risk factor. If the patient she had high BMI, 30 or over, or if the patient she had macrosomia or previous gestation or family history of diabetes, any affinity with high prevalence of the diabetes. For this one, offer a woman with this risk factor testing gestational diabetes. Don't use fasting blood glucose. This is the one. And use 75 grams OGTT for women who have had gestational in previous. Offer early monitoring of the blood glucose. Yeah, or give her OGTT. Offer woman with any other risk factor for gestational, she will come at 24, 28 weeks and she will do the OGTT. Because this is a patient she had risk, you will do as early as you can. As early as possible, you will test this patient. Yeah.
24-year-old woman.
Any doctor,
24-year-old.
Dr. Sana, you want to continue? Any other doctor you want to participate? Or Sana, she will carry on? Anyone?
I want.
You want? It is okay. Anyone, if you want, خلاص, it is okay, no problem. Yeah, it is okay.
A 24-year-old woman at 24 week gestation has tiredness. HB is 96 gram per L and ferritin is low. She is stable and has no bleeding and can tolerate tablets. What is the most appropriate initial management?
The patient, she's
Oral
20.
iron, ma'am. She can tolerate tablets.
Yeah. If she can tolerate the oral iron, it will be better. Because usually iron deficiency anemia, I think we have the TOG and we have some guideline in this one I also for you in the group, very important because they like to bring iron deficiency. Sometimes they will ask you the patient in the first trimester or second trimester or third trimester or the patient she had emergency. So concentrate in this question. If the patient she had her hemoglobin a little bit low and the patient she is fine, you can advise the patient by the diet. If the patient her hemoglobin is low, like this one, 96 gram, and the patient she can tolerate the oral, and still early, like in the second trimester, like our patient here, 24 weeks, this is when it can be by oral, because they will repeat. If I want to confirm iron, it will be confirmed by serum ferritin. Also, this in September 20, they ask how you will confirm. In the third trimester, if you remember the patient with anemia, if you remember the patient 38 week and she came with dizziness, that time how he will manage the patient dizziness and 38 week, how it will be managed, doctor? I want to hear the participant with me. The question, the patient 38 week and she came with dizziness, what you will do? share. So if we discuss together, we cannot forget. Yes, doctor. Your voice, doctor?
Blood transfusion, ma'am.
What is the other? Because this recall, and they will bring again the recall. What about the other? 38 and dizziness. Because 38 for us, it is near to deliver. Yes, correct?
Things in the sense you start putting them in the background to make these little platforms show me place.
Yes. Anyone to talk?
Ayan, doctor.
Yes.
IV, ayan, doctor.
Yes, Nabila? IV iron.
IV.
Yes, Dr. Nabila. IV iron. Because we mentioned that we will not do blood transfusion unless you have emergency. The patient, she had antenatal bleeding, she bleed a lot. The patient, she had PPH, she bleed a lot, and you want to replace this one. Otherwise, 38 is still early. Because for us, if we can deliver the patient maybe till 41 week. If you give iron injection, it will be better. Remember, the blood transfusion, unless emergency, the iron IV, unless the patient she is near to term, because you cannot correct by the iron. Remember, in the second trimester, it will be by iron oral. Remember, if the patient she is fine, can be by time. All this one can come exam question again. Yeah. Then.
A 28-year-old woman with known epilepsy is in labor at 39-week gestation. She develops a generalized tonic-clonic seizure lasting 4 minutes. Airway support and left lateral positioning are started. What is the most appropriate drug treatment?
She is in labor at 39 weeks, and she developed generalized tonic-clonic seizure lasting 4 minutes. Airway support and left lateral, that means you do ABC. What is the most appropriate drug treatment you will give here to the patient? And remember this
IV
one.
antiepileptics. IV antiepileptics.
Yeah, so answer.
IV lorazepam.
Yeah, it will be IV lorazepam. If you remember which exam, I think January 19, they give you all the option for the patient epileptic. The patient, they tell you when the patient in the outpatient, if you remember that time she had no cannula, not like our patient in labor, and she had cannula. That question, they will give the patient the diazepam. It can be rectal, you can give the patient oral. Yeah, according to your situation, according to your patient. But if the patient in labor, the first option, it will be IV lorazepam. Yeah, correct. And I will keep for you here. And if the patient she had any seizure lasting more than 5 minutes, is unusual and represent high risk of to convulsion status epilepticus. So you will give the patient lorazepam. If the patient, another important point here, if there is no study, the optimal management of epileptic seizure in labor outweighed pregnancy, benzodiazepine as the drug of choice in status epilepticus. In those with intravenous access, like our patient here in labor, and she had intravenous access, we can give the lorazepam. It will be given as intravenous dose of 0.1 milligram per kg, and usually 4 milligram bolus with the further dose after 10 to 20. Is preferred diazepam. It can be, if you have not give lorazepam, if you have no in the option lorazepam, you can give the patient diazepam 5 to 10 milligram administered slowly intravenous. If there is no intravenous access, the patient, you can see the dose here IV 5 to 10. Remember this point. If the patient she had no access, you can give the patient 10 to 20 like the patient we tell in the OPD. Yeah. And if seizure are not controlled, consider administration of phenytoin. Exam, you give this one and still the patient, the seizure not controlled. The loading dose of phenytoin, it will be 10 to 15 milligram by intravenous infusion. That means, remember, the patient she had no cannula in the outpatient. If the question came again, it can be the 10 to 20, it will be rectal. The patient, the first option, it will be the lorazepam IV. The second option, it will be diazepam IV. The patient she had status epilepticus, it can be benzodiazepine. This all important, and can they repeat this exam? Yeah. So the epilepsy, write in your note. Epilepsy, you will go through it. I want to write for you.
Okay. A 26-year-old woman with epilepsy attends pre-pregnancy counseling. She asks which anti-epileptic drug has strongest association with congenital malformation and neurodevelopmental problem. Which drug is the ma'am, the students are answering, I cannot read. Which drug is the greatest concern? Obviously, sodium valproate, which we are studying from MRCOG-1.
Yeah, the sodium valproate, this is one. And come, which you recall, I think September 21, they ask you, if they tell you the killer, if the patient she had big problem with the congenital animal, it will be the sodium valproate. If you remember, it will be 30 to 40% and 10% congenital animal. So this is a high risk, the drug, it will be avoided. And this one, the table I keep for you here because it is very important. Here we have the lamotrigine. Many times they will ask you what is a possible congenital malformation. It will be the cardiac defect. This one, the carbamazepine. We have the lamotrigine, the best drug, and they come in the exam before they ask the lamotrigine from the safest drug, but it can be the cardiac defect. We have levetiracetam. It is good, but can be cardiac defect and neural tube defect. And which drug come in the exam? Phenytoin, facial cleft. And the problem here from the sodium valproate, you can see the risk of congenital 10%, I tell you in September 21, and it will be dose dependent. Topiramate also cardiac defect, facial cleft, and monotherapy with polytherapy, it will be high, it will be 6 to 10. This table is very important about the drug because many times in the exam they ask about the drug. And which is the safest, lamotrigine, and the other one, the levetiracetam, and the one problem it will be the sodium valproate. Yeah.
A 31-year-old woman at 36-week gestation has intrahepatic cholestasis of pregnancy. Her peak bile acid are 62 micromole per L. She has no other risk factor and fetal growth is normal. What time of birth is most appropriate? 36 weeks. 38 to 39.
Then this because remaining the patient at 36 weeks and the bile acid 62. So what timing of birth most appropriate? Because the patient mild risk, we have moderate risk, and we have the high risk. And according to this one, we will deliver the patient. Yeah, intrahepatic cholestasis, it will come in the exam. It can be 2 questions in the exam. They can ask anything, and many times they ask any point for this one. Then here about the risk of the bile acid and what time I will deliver the patient if she had mild, she had moderate, she had severe this one, intrahepatic cholestasis. Then will be what?
Ma'am, A 38 to 39.
According to the range.
According to the range.
Yeah, you are correct. We have gestational pruritus if less than 19. That means the patient she had itching and big bile acid less than 19. The patient she had no intrahepatic, so we had only gestational pruritus. We have the mild, it will be the range from 19 to 39. We have the moderate 14 to 99, and we have the severe 100 or more. So for this what time I will deliver the patient, and here they will bring for you the request stillbirth. It will be more with the severe if you can observe. After that mild, after that moderate. For this reason, the delivery time also it will be different. If your patient here 19 to 39, the risk of stillbirth is similar to the background risk. They can bring this one doctor, and if the patient has this one consider plan birth at 39 of gestation in woman with the moderate 40 to 99, like your patient here, Dr. Sana, and if the patient she is high risk, the severe one, delivers the patient at 35, 36 weeks because the risk of IUFD and all this complication don't wait more than this one. Also, this slide very important. You will revise before you will go because might come exam question again. Because they bring this one in the previous record. The one the patient she had bile acid 19 to 39. So it can be at similar to have background risk. You can deliver the patient at 40 weeks. This one can repeat again.
Okay. A 24-week monochorionic dimenoid pregnancy is referred to fetal medicine. Ultrasound shows the deepest vertical pool of 9 cm around twin A and the absent visible bladder in twin B. Dopplers are normal. Both fetal hearts are active. What is the most likely Quintero stage?
Now what? Because we have the stage 1, 2, and 3, and 4. And after that, we'll treat the patient. Here's the patient's vertical bore 9 centimeter and absent visible bladder. In between, yeah, and Doppler are normal. And both fetal heart are. It will be stage
2.
2. Yeah, correct. And this one from the update guideline because it's updating 24. Yeah, the monochorionic twin it will update. So your baby here, the bladder is not visible. And if you have Doppler study, or you have the problem in the Doppler, it will be 3. And if you have the fetal effusion, ascites, it will be 4. And if one of the both twin die, it will be 4. This is another that one you revise because you have selective growth restriction. It will be 1, 2, and 3. Revise this one. I will keep for you here in the session. I revise the stages. They may ask the TTS stage.
A woman has uncomplicated dichorion diamnion twin pregnancy. Growth is normal in both twins. Dopplers are normal and there are no maternal complications. She asked when planned birth should be offered. What is the recommended timing?
She's die and she's fine. She asked you what time, doctor, I can deliver.
Dichorion diamnion, everything is normal.
Because if you
47.
start, yes, now mono, you will deliver the patient before 34 weeks. Yeah. Another exam question, I think in January 24, you will deliver the patient 33 plus 6. If the patient she had monochorionic diamniotic, this is the patient she will deliver between 36, 37. If the patient die, you can deliver the patient till 37 weeks, no problem. And she can deliver normal.
37 plus 0 weeks.
Yeah. And the other one, the mono, she will deliver by cesarean section. And this one she can deliver by normal delivery if she had no other obstetric indication. Yes, correct.
A woman is found at booking to have anti-D antibodies. The level is below the threshold for fetal medicine referral. There is no previous history of an affected baby. What is the most appropriate follow-up?
They replace the previous guideline with the other one. Yeah, I post for you in the group. You are following me in the group or no? If any step, you I am posting in the group. Yeah. So here what? The patient she have anti-D and plus threshold for fetal medicine referrer because anti-D we have the 4 and 15. Yeah. This one we have moderate and we have severe. Anti-C we have 7.5 and we have 20. Anti-K any level will refer the patient. Here they ask what is appropriate follow-up. That means this it is positive. How you will follow the patient? I post for
Ma'am,
you.
option C. Option C.
Yeah. Yes, Salah. Correct. And this is the one I tell you to replace the previous guideline. I post for you here. Let me post again. Front of you it will come. So you will not forget. In the recall group. Our main group it is recall group. I am posting most of there. Here from 20, then I will test the patient every 2 weeks until delivery. Yeah, you are correct. Yes, and here testing monthly until 28. Yeah, our main group is recall group.
Okay. A woman is 14-week pregnant. Her previous pregnancy ended in preterm pre-labor rupture of membrane at 22 weeks. She asked whether she needs cervical length surveillance. What history supports serial transvaginal cervical length assessment and possible cerclage?
Yes, repeated many times exam question. They will tell you a patient from her history, the patient ultrasound indicated circulage, the history indicated circulage, and they repeat the same question, and most of you will make mistake. How we will do the surveillance of by ultrasound and what time we will do immediately at 14-week elective circulage. Here, the patient she tell you she had previous pregnancy ended by rupture of membrane at 22 week. Additional to this one, if she had any problem, what time it will be?
B.
Previous from? Yeah, will be correct. And I keep for you the slide here, doctor, so you revise. Because if we have the patient history indicated circulate, this will be the most important one. The patient she had the pregnancy 3 or more previous preterm years. This is the one only. It will be from her history. I will do the elective. The other one, and it's very confusing. This is the one. Woman with single-term pregnancy and history spontaneous second trimester loss or preterm years. Because she had no more than 3. She had had woman with history of one or more spontaneous second trimester losses, like our question here. If the patient she had one or more, that means I will not do elective circulage immediately. So, or preterm birth who undergoing ultrasound surveillance of cervical lenses, it will be offer circulage if the surface it will become less than 25 millimeter or less gestation than 24 weeks. That means this is the one, the indication to follow the patient by ultrasound. This is the one. So ultrasound indicated circulage. It is not recommended for funneling of the cervix, dilatation of internal os. This because they will tell you the patient she has two second trimester miscarriage. This is the one I will follow the patient. Then for women with the single tone pregnancy and no other risk factor for preterm birth, insertion of circulage, it is not recommended in women who have short surface incidentally. That means you bring the patient or you have any issue, you do ultrasound and incidentally the patient she had short cervix. She had no other indication. So then here it is not indicated for circulage. Who should be offered serial sonographer surveillance? Most of the exam question it will come here. The woman with history of spontaneous second trimester losses or preterm birth and who have not undergone history indicated circulage. Because history indicated circulage, it will be 3 or more. The exam questions they will tell you the patient she had two second trimester, the patient she had one second trimester, one preterm labor. This is the one need to follow by ultrasound. And it will be from 16 to 24 weeks. And during this period, if any time the patient she has short cervix, you will consider to give the patient cervical circulage. So please concentrate in this point because they will repeat the exam. They will tell you it is ultrasound indicated circulage or the patient history indicated circulage. Or if the patient incidentally no need for circulage.
Okay, a 20-week pregnant woman. A 20-week pregnant woman attend the antenatal clinic during influenza season. She has no contraindication and asks which vaccine is routinely recommended in pregnancy. What would be offered?
Yellow, shingles, or rubella, small. Which one? The live vaccine, I will not. BCG, no. Human by yellow fever, no. In a special situation. Yeah, oral typhoid, no. Or rubella, we cancel the patient after
Flu
delivery.
vaccine. Flu vaccine.
Yeah, flu vaccine. I think this also in Recall 24. Yeah, from the flu vaccine. This is the one vaccinated contraindication you will not give. And this vaccine is specially indicated in pregnancy, like influenza, this is our question, and the whooping cough, and diphtheria and tetanus. This is the one we are giving. And vaccine recommended in pregnancy in certain situation. If you remember this one in the old recall, they tell you yellow fever vaccine. I think the patient she is traveling to area with yellow fever vaccine. Yes.
A 34-year-old multiparous woman at 36 plus 4-week presents with painless, fresh vaginal bleeding. She is hemodynamically stable. CTG is reassuring. Her 32-week scan showed placenta previa completely covering the internal os. What is the most appropriate management?
The antepartum placenta previa. They will give you any question from the APH. Then they tell you here the patient is 36 weeks plus 4. That means she is fine, not severely premature. And the patient she know from before she had placenta previa and she will resent this bleeding. Now here what I will do. Shall I wait? I give steroid and I will wait more than this, or shall I will go for cesarean? Because you have no other option. Tocolysis if the patient she
Tocolysis. We need to do tocolysis, ma'am.
usually if the patient the extensional egg less than this one and the patient she is stable mild vaginal bleeding, they consider to give tocolysis only to give steroid like 48 hours, but not routine tocolysis with bleeding. Speculum only the patient she is bleeding and she know that in the previous. So what what is the best here, doctor, in the chat? What is the best for this patient? 36 plus and she came with bleeding, she's placenta previa. What I will do?
It's emergency C-section.
Yeah, I will not wait more than this. It is fine to wait till 36 plus. You are approaching 37 week. it is okay. But remember the exam question, if the patient, I think she is 33, 34, recall, and the patient, she came with vaginal bleeding, any patient, she had placenta previa, better you will admit the patient at least 24 week and see. Any patient, she had placenta previa at 32, 31, and she had short surface, also better you will give steroid and admit. And that when if the patient, she is mild bleeding, better you will keep in the hospital, give steroid, give tocolysis, still you will give steroid, and after that stop the tocolysis. This all about. But here 36 plus 4 and the patient, she's bleeding and she's already diagnosed, she had placenta previa, deliver the patient.
A woman has spontaneous vaginal birth. 10 minutes later, she has heavy vaginal bleeding. Estimated blood loss is 900 ml. The uterus is soft and enlarged. Her pulse is 115 beats per minute and BP is 95 by 60 millimeter of mercury. What is the first management step?
You have BPH. And the patient, she bleed 900 ml. And the pulse rate with 15 increasing. Blood pressure, she's hypotensive. That means the patient, she's not okay. And she had vaginal bleeding, and that means she's a tonic uterus. Then what he will do? And the exam question, doctor, the BPH, most of us, most of you will not answer the exam question in the BPH. Tell me why. Because they will give you all the options like this. And after that, you will think, did I do uterine massage? Or first I will start by what? What is it? We need to go by step. Whatever not done, you will do. Our patient here, she is hypotensive, she's tachycardic, and she bleed 905, 900 ml, and they give you all. If you have BPH, the first step, it will be what? The drill of the BPH.
Call for help.
IV
Yeah,
for
yes.
help.
Yeah. The first one is the BPH, you will call for help. And after that, you will follow. But in the exam question, I want you to concentrate why. If today we go and see September 22, they give you all the option. Me, if I want to start with answer the question, I will ask myself, do I do uterine massage first, or do I will do uterotonic first, or I will give a fluid first? Really, the BPH, you know what to do. And you can, this one, you remember all this one. Yeah, step by step. But when you will come to the exam question, you cannot answer. For this reason, I want you to concentrate. Why, Doctor C? Like this question, very easy. If I have the real of BPH, the first one I will call for help. I will not struggle alone. I will want to the senior midwife, the senior nurse. I want to inform the blood bank. I want to see the blood group of this patient. When she want to give cannula, once you want, like if you do the drill. But if the exam question see which what is done and which is not done, and after that go step by step. In the exam questions, they will guide you in the second step. Like if they want to bypass uterotonic drugs, they will tell you the patient, she delivers, the placenta deliver complete, and the uterus is contracted, and the patient is still bleeding. That time, what the fluid, that mean it is given, call for help, all this one given. That mean the patient you want to examine. If you have the patient under epidural, it will be under light. You can see the patient maybe we remember the 40, maybe the patient she had trauma. The first one it will be excluded. The second one, if you remember, I think if I have a good memory, I will remember September 22. The patient, they tell you she delivers the second, not second stage cesarean section. The patient, she's 8 centimeter and she had some problems. They will go for cesarean, and after that, the patient, she had bladder injury, and after that, they repair the bladder, and after that, after they close finish, the patient, she's still bleeding. This means maybe I need to go back to the theater. Still, the patient, she had problem. Maybe they stay a long time there. So you need to do exploration for this one under the theater again. If they tell you, like the patient placenta deliver, but the patient multi or she had polyhydramnios or anything like this, that means the patient, she had this one, ethnic uterus. You start by the drug. If the patient, she had severe bleeding, that means you want to replace. Yeah, you will give the uterotonic one by one according to the step, and after that we'll come to the blood, the first crystalloid, and after that the colloid, the BABIKER pieces. And if I will give BABIKER pieces, it will be four and four fresh plasma, and after that you will give the blood till, because the first we will give O negative because we have a major BPH, you cannot wait for the result. And after that, according to the exam questions, they will tell you the patient, she had result of coagulation, this is the result. And after that, they want you to replace the contrast the platelet, our target 75, and they give you in the exam 50, that means you want to give the platelet. They will give you like 1.5 the fibrinogen, that means I want to give cryoprecipitate, because this is the one it will be corrected first. If you give cryoprecipitate, maybe the bleeding also it will stop. Another exam question, they tell you the patient she is bleeding, now she is okay, her hemoglobin 8, her blood 80, and the vital state. This one I will not give anything. And after that, remember the important point in the BPH in the exam, the bleeding ongoing or the bleeding stop. That means bleeding stop, I will correct one by one and I am fine. But if the bleeding is still ongoing, that means you want to correct and you were afraid from the DIC, the BPH. So try in the exam to answer the BPH, and it will come 3 exam question in the BPH. Believe me.
A primigravida delivers the fetal head after prolonged second stage. The head retract again against the perineum and gentle axial traction fell. Shoulder dystocia is diagnosed. Help has been called. What is the first line manual? Mick Robert.
Yeah, more proper than this repeat exam question, remember, because emergency is must doctor to go through it. We have the first one, the call for help, and after that, the McRobert maneuver. And remember another exam question, McRobert, it will review. If you remember the recall, this one, the picture in the previous recall, the head deliver in the first stage, it will be McRobert, and after that, it will release McRobert by 90%. And after that, I will combine McRobert with suprapubic pressure, and after that, deliver of the posterior arm according what you it is easy for you, and after that internal maneuver, the wood screw and reverse wood screw, and that will be the first one Robin one, and after that I will go for the all four, and after that this is the intermediate stage and this is the first stage, and after that consider this one the Vinelli maneuver or fracture or this one, it will be the red flag here because here the baby outcome it will be delivered by very low outcome score. So remember all this step in this one, and this is the macrober maneuver. It will be combined by suprapubic pressure, and after that reveal this one. Yeah, yes, doctor, correct.
A 15-year-old girl present with heavy menstrual bleeding since menarche. She reports recurrent epistaxis and prolonged bleeding after dental extraction. She is hemodynamically stable. The pregnancy test is negative and pelvic examination is normal. What is the most appropriate first-line medical treatment for heavy bleeding while arranging hematology assessment?
Yeah, 15 years with the menstrual bleeding since menarche. That means this patient she have problem. We have this dog, yeah, heavy menstrual bleeding. This patient may be of von Willebrand disease. They will present like this. And this dog, they repeat this exam. One exam, I think they ask what investigation to be done. And one another exam, they ask how this patient to be treated. So here, yeah, Dr. Sana, if the patient like this, you can give what?
Tranexamic acid, madam.
Yeah. Yeah. You will give this one. Yes, and try if you have time to revise the talk. Heavy menstrual
A
bleeding in
32-year-old
adolescent.
woman.
Yeah, correct.
A 32-year-old woman has 18 months of infertility, dysmenorrhea, deep dyspareunia, and chronic pelvic pain. Pelvic ultrasound is normal. She wishes to conceive and doesn't want hormonal suppression. What is the most appropriate next step?
And endometriosis. Yeah. She had problem with infertility. She had dysmenorrhea and dyspareunia, and chronic pelvic pain. They give you the full picture of endometriosis. Endometriosis, I don't know, they like it. They update nice guideline in 24. They give endometriosis with subfertility. They give endometriosis with surgery. They give endometriosis with everything. Yeah. So here, if the patient, she had fertility issue and dysmenorrhea and dyspareunia and pelvic pain, ultrasound come normal. How you treat this patient?
Because she doesn't want hormonal suppression, so we go for laparoscopy, madam.
Yeah, go for laparoscopy, and this is a mechanism of related to subfertility. You have the dyspareunia, our case here. We have anatomical distortion effect on the egg also, endometrial receptivity, pelvic surgery, or ovarian reserve. Also, if the patient she had big endometrium and you do surgery, also it will affect the patient ovarian reserve and subfertility. Yeah, if you have suspicion like this, go for surgery. If the patient maybe she had big endometrioma, you will remove. If the patient she had adhesion, you will do the adhesiolysis. I will keep for you this one, read in your time. Yeah, Dr. Sana.
A 28-year-old woman with PCOS has 14 months of infertility and oligomenorrhea. Her partner semen's analysis is normal and tubal patency is confirmed. BMI is 29.
Mhm. You have the PCO. Now they tell it is polyendocrine metabolic ovarian syndrome. Yeah, they change. Long years, we know the PCO. Now they change the name, the BMOS, the BMOS. Yeah. And this one is not yet released. I think it will be released in December. Yeah. So if the patient she had PCO, which is better? She had infertility. Her partner semen normal. How you will do?
Letrozole.
Yeah. The first option will be letrozole. Yes. You are correct.
Thank you.
Welcome. Mhm.
Okay. A 29-year-old nulliparous woman present with irregular heavy vaginal bleeding. Endometrial biopsy confirms atypical endometrial hyperplasia. She strongly wishes to preserve fertility and is counseled by gynecological oncology team. MRI shows no myometrial invasion. What is the most appropriate fertility sparing management?
Hmm. Because the patient irregular heavy bleeding, and after that they did for high endometrial biopsy, confirm atypical endometrial hyperplasia. And the patient, she's young, only she's 29 years old, and she had wishes of fertility. Usually, the patient she had atypical endometrial hyperplasia, it will be treated by hysterectomy. Yeah, but this patient she wants sparing treatment. How you will treat her? Yes, doctor in the chat.
LNG-IS Marina.
Yeah. The first option, it will be Marina, because they tell you the patient, the MRI show no myometrial invasion. That means the patient, she is fine. The patient, she is elder and she doesn't want to remove her uterus. That one, if you remember, because usually if the patient, she had endometrial without atypia, this is the one it will be treated by the Marina. And if the patient she refused to take Marina, the second line it will be the progesterone. But if the patient she is atypical endometrial hyperplasia, elder patient will be laparoscopic bilateral salpingo-ovarectomy. Anyone she had wishes of fertility will insert this one. And if the patient she is normal, she will refer the patient to fertility specialist, and he will be the woman wishing to retain their fertility should be counseled about the risk of underlying malignancy and suspected progression to endometrial cancer. You will tell her because your risk is very high. Pre-treatment in the investigation should aim to rule out invasive endometrial cancer. In our questions, they tell they did MRI or maybe biopsy. Histology imaging and tumor marker results should be reviewed in multidisciplinary meeting and plan for management and ongoing endometrial surveillance. First line treatment, it will be marine and should be recommended with oral as second best alternative. But if they ask first, it will be the marine. Once fertility is no longer required, hysterectomy should be over in view of high risk of disease relapse. You will tell her only you get a baby. After the baby, he will go for the definite treatment and it will be bilateral salpingo-ovarectomy and hysterectomy because he had high risk. If you remember, the risk for this patient will be like 27.5 in the atypical endometrial hyperplasia, and coexisting malignancy will be 43. Another record question, doctor. Yes.
A 38-year-old woman was treated by excision for cervical glandular intraepithelial neoplasia. She is under extended follow-up. Her latest follow-up sample is high-risk HPV positive. What is the most appropriate next step in this patient?
Treated by excision for cervical glandular intraepithelial neoplasia, and now HPV is positive. Yeah, what you will do if you have HPV positive, doctor? The chat. You can talk, doctor, no problem. Right, you can talk.
Yeah.
Nabila,
Sorry?
Nuhu, Win, I am.
C, doctor. C.
Yes.
HPV test in 6 months.
It is positive now. What if you have positive, Nabila? Well, what you will do?
Colposcopy. For
Yeah.
colposcopy.
Colposcopy.
High-risk.
Immediately go for the
Focus.
colposcopy. Yeah. The patient, she had CIN1 on biopsy, cervical cancer. I am writing for you the exam question. How many questions now? Cervical cancer, it is very important. It will come for follow-up like this, or the patient, she had simple hysterectomy for follow-up. This one, it will come to exam question, and usually it will come SBA question. Our patient here, if we have the CIN one on biopsy or colposcopy impression, because this is, I tell you all the time, there is the patient in the cervical screening according to the patient risk. If the patient she is low risk, like CIN1, or if the patient she is CIN2 and CIN is high risk, and this is the more highest risk, CGIN. For CIN2 and 3, this it will be only one test of cure. You will ask the patient, like Nabila, if you mentioned, it will be 6 months. And after that, I tell you, before we are doing only cytology. Now we are depending mainly in human papilloma virus trial, because it is very important and cost effective. If negative, the patient will come in 3 years. If positive, the patient will most all the time positive, you will do cytology. Negative, the patient will be abnormal, refer to colposcopy. The one here, she is low risk. The patient recall in 12 months. If her human papilloma negative, usually if negative, you are him. Ask the patient to come in 3 years. If positive, you will do cytology immediately. If negative, the patient she will come after 1 year. And after that, when she will come again, she will do the human papilloma virus trial. And after that, you will do cytology. Cytology negative again, she will come in 3 years. If cytology abnormal, usually cytology abnormal positive, this patient high risk, it will be referred to colposcopy. And here it will be the same. The difference here in the CGIN, this is the one high risk group. You remember here only we have one test of cure, and here we have two tests of cure, here and here. The patient she will come, and after that you will follow the patient for 9 years. Your patient positive, immediately the exam question will be referred to colposcopy. Yes, correct. Remember,
A
cervical cancer
29
cannot read, you will do before the exam. Fast revision, yes.
A 29-year-old woman is diagnosed at 28 weeks with invasive cervical cancer. MDT review confirms that treatment can be delayed briefly to improve the fetal maturity. She has received corticosteroid. What is the most appropriate planned timing of the delivery for this patient?
Mhm. Now we'll come to the oncology, one by one. If you have paper, please write. We have the oncology, the exam question. The vulval cancer, it will come SPA question. And I expect it will come. Why? Because we have the BASH guideline update in 24. Yes, by post for you in the group, we will go through it. And the other one, we have this one, lichen sclerosis. I think update in 25 or in 26. So vulval cancer, it will come. Exam question may be 2 SBA. Hey, here we have the cervical cancer. Cervical cancer also they will bring 2 questions usually, and usually it will be like SBA, not like ovarian cancer. Most of the exam questions they will give you the long scenario about the staging and how to treat. Here your patient, Dr. Sanash, is 28 weeks with invasive, and MDT review confirms that treatment can be delayed because it will involve the MDT with you. They tell you you can delay this one, and if they tell you you can delay this patient, what time you will deliver? Reservation chat cervical
34 weeks.
Yeah, it will be, yes. In the chat also, doctor, you can talk and participate with us. So, yeah, it will be 34 week after.
34.
Yes, correct, doctor. She is, it will be 34 week, allow maternal cancer treatment to start promptly. I bring for you because we have the cervical cancer update in 25. Please promise me you will read it because cancer all update in 25. Yeah, we have cervical cancer here, special situation during pregnancy, and where they mention here, it will be around 34 weeks after the maturity here. When delivered as tertiary center with appropriate neonatal care delivery by classical cesarean section and radical hysterectomy, and at the same time undertaken no later than 34 weeks of gestation. Yeah, so this one, remember, we have this one because we have repeat exam question. If you remember the other one here, they will give you colposcopy clinical examination. They did here. If the patient she had 1A2 or 1B1, or is the patient 1B2, or is the patient here? Here you will follow the patient. Here, if the patient less than 22 gestational age, that means early, you will do pelvic lymph node dissection. If positive, please terminate. Because early and patient is high risk. The lymph node is positive. Better here you will terminate. If the patient negative, you will do a simple trachelectomy, or you will delay the definite treatment after delivery, according to this one. If the patient more than 22 weeks, that means the extensional age it is okay, and do non-adjuvant treatment or delay the definite treatment. According to the exam, you can answer. Here it will be the same if the patient 1B2, because here we are going here, the more advanced cancer. cancer. Here, less than 22, also the pelvic lymph node positive, better you will terminate because it's still early. If you can choose the pelvic lymph node, this one or non-adjuvant chemotherapy. If negative, neoadjuvant chemotherapy or delay the treatment till after delivery. If more than this one, non-adjuvant chemotherapy or delay. Or if the patient less beyond B3, it will be more than 22, it will be treatment and delay. If the patient most of the time, they tell you the gestational age is more and the pelvic lymph node dissection is negative, better you will delay. And delivery, it will be around 34 weeks and it will be by classical cesarean section. They repeat this question. They like cervical cancer in pregnancy. Yes.
A 58-year-old woman present with persistent abdominal bloating, early satiety, and urinary frequency for 3 months. Examination is normal. What is the most appropriate initial investigation in primary care for this patient? CA 125 because
Yeah,
she has bloating, early satiety, urinary frequency.
look like the impression like ovarian cancer. Yeah, if I have any suspicion patient, she is under 58 years and with all this symptom, urinary frequency and bloating and satiety, it will be CA 125. Yeah, and you will determine this one because established we have diagnosis, preoperative testing, calculate the risk of malignancy index for the woman under 40 years, check the serum because if the patient younger, I need to check the PTHCG, alpha fetable LDH to exclude germ cell tumor. And here you will do the risk of malignancy index. If more than 200, it refer the patient to gynecological cancer center specialist with this symptom. If the risk of malignancy become for you high. And after that, there they will perform CT scan, abdomen and pelvis for staging. And if clinical CA and pelvic ultrasound suggest ovarian cancer, the CT chest may be performed for staging. You will complete, first you will do CT abdomen and pelvis, and after that you will do chest to complete the staging with this symptom. But if they answer it for you, like CA125, most of the cancer is patient elder, you will check the CA125, you think maybe the patient she had or epithelial ovarian cancer. Yes, doctor.
A 64-year-old woman has suspected advanced epithelial ovarian cancer. CT suggests that disease is resectable. She is fit for surgery. What is the most appropriate initial management?
We mentioned the ovarian cancer, most of the time it will come the MKO. They will give you a scenario like this and they will ask you to stage and after that you will treat. Yeah. So the patient, she had 64 and the patient, she is fit for surgery. She had no comorbidity. So what you will do here?
Surgery, ma'am?
Yeah, you will do the surgery. Yes, the primary surgery. Yes, doctor. Yeah, correct, doctor. Yeah, talk with me. I will not feel lonely with Sana only. Talk and share. Yes, doctor. Here you will do the staging surgery, and this is the step of staging. And if the patient she had mucinous, you will add a appendectomy to the patient, and after that you will do the primary debulking surgery, and after that decide the patient she will receive chemotherapy or not. Yeah.
A woman has an epithelial ovarian cancer involving both ovaries with omental deposits confirmed at surgery. There are no pleural effusion and no distant metastasis. What is the FICO stage?
In the exam, they will ask you how to stay. So this oncology, this mark in your hand, don't miss it. Yes. Then.
FICO stage 3.
Was ovaries or mental deposit at surgery. There are no pleural effusion and no distant metastasis. That means you are not reached stage 4. Where are you here? Stage 4 or stage 3? Because if you have in the pelvis, it will be stage 2. When you go retroperitoneal or lymph node involvement, that means you are in stage 3. Distant metastasis, local metastasis, stage 4A. Distant metastasis, pleural effusion, stage 4. Then here what? You will keep this in front of you till you will go to the exam. Staging of the ovarian cancer, staging of the vulval, cervical, and endometrial. Endometrial, they make it more complicated. Endometrial will come exam question because they like it. If you remember, less than 50, more than 50, and now with subdivision. Yes?
Maybe stage 3. FICO stage 3.
Yeah, you are correct. And keep this in front of you till the exam day. Yes. Because if you have stage 2, دكتورة سناء, it will be only with the pelvic extension below the pelvic brim or peritoneal cancer. Here, implant in the uterus or fallopian tube, extension to the pelvic intraperitoneal tissue. When it come out or retro this lymph node, it will be 3. If you have distant metastasis, if you have pleural effusion with the positive cytology, it will be A. Branchial metastasis, it will be stage 4. Yeah. This one you will remember. It is must to remember. You will force yourself to finish this exam. يلا إن شاء الله
Inshallah.
إن شاء الله خير. يا رب.
A 63-year-old woman has postmenopausal bleeding, endometrial biopsy confirmed grade 1 endometrial adenocarcinoma, endometrioid adenocarcinoma. MRI shows disease confined to the uterus with superficial myometrial invasion. What is the most appropriate primary treatment? Okay.
Yeah. Superficial myometrial invasion. The patient postmenopausal bleeding, and she had endometrioid adenocarcinoma. Usually, I will stage by MRI if they ask you for the staging. And if you remember the exam questions, they tell you the patient she is afraid from MRI or she had phobia for MRI, you can use the CT. But usually staging by MRI. Then what?
Surgery, ma'am.
Uh-huh.
Surgery, total hysterectomy, and bilateral salpingo-oophorectomy.
Yes.
Because
Yeah.
he is
Yeah,
grade 1
correct.
endometrial adenocarcinoma.
Yes. No, yes, correct. Total hysterectomy, bilateral salpingo-oophorectomy. And I keep for you this one because what time we'll do this one. If you have low risk, the patient FIGO grade 1 or stage 1B and no lymphovascular space invasion, or if you have FIGO grade 2 stage 1A and no lymphovascular space invasion, this is the patient she will be low risk. Keep this one or please take this one and put in your group. No adjuvant treatment here. So it will be only hysterectomy and bilateral salpingo-oophorectomy. If the patient is intermediate risk, this we need to add the vaginal brachytherapy. And this recall, yeah, remember this one. And if the patient had high intermediate risk, it consider external beam radiation versus vaginal brachytherapy. And if the patient is very high risk, it will be FIGO grade 3 and consider external beam radiation versus vaginal brachytherapy, consider adjuvant chemotherapy. This table, it is very important when you will come to endometrial cancer. And I keep for you this one, it will be easy for you. The one less than 50 and the patient she is low risk, this is the one only his surgery. The one intermediate risk, you will add vaginal brachytherapy. The patient had risk, you will add for her external beam radiation therapy. Please keep this one in the group so you remember. You took doctor?
A 34-year-old.
Then? Mm-hmm.
A 34-year-old woman present with primary infertility for 2 years. She has regular cycles and her partner's semen analysis is normal. HSG shows bilateral tubal occlusion. There is no hydrosalpingo seen on the ultrasound. What is the most appropriate management for this lady?
Mm-hmm. You expect fertility problem, usually 3 questions. And now, alhamdulillah, the fertility nice guideline, it is update. Yeah, you will go through the fertility nice guideline, see what is new there, because they can bring any exam question. Sometimes the doctors, they will tell you, if this guideline update less than 6 months, it will not come. No, because this guideline, if they release for you, like April, this guideline may be since December, it is there with them. So don't think about this one. Any guideline update, go through it before you go to the exam. Then here, the patient, her partner semen analysis is normal, and the patient, she had bilateral occlusion. So what is the best treatment for this patient?
So bilateral tubal occlusion needs tubal surgery.
Mm-hmm.
IVF.
IVF, yeah.
IVF.
Yes, doctor. IVF, bilateral occlusion. No. If you have the proximal, this one tubal occlusion, you can do the surgery. If you have minimal tubal problem, you can do the surgery. But if you have bilateral like this one, and if the patient she had hydrosalpinx, you remember, you will do this one salpingectomy before the patient she will go for IVF. Yes. Yeah, bilateral tubal occlusion is significant female factor cause of infertility. In this situation, assisted conception with IVF is the most appropriate treatment rather than ovulation induction or excision. Yes, correct.
The couple has been trying to conceive for 18 months. The woman has regular cycles and normal. Initial investigation, her partner's semen analysis shows
You want to help? Take rest for a while, and after that, continue. I feel you are. Huh?
No, it's okay. Practice more.
Yeah, okay. Till you will feel tired, tell me, because we have still many questions. Anytime you
Okay.
feel you cannot do, tell us, no problem.
Okay. A couple has been trying to conceive for 18 months. The woman has regular cycle and normal initial investigation. Her partner's semen analysis show mild oligospermia. There is no azoospermia or severe sperm deficiency. When should the semen analysis ideally be repeated?
Mhm.
Ma'am, 3 months ideally should be repeated.
Yeah, this will be a bit.
That's 3 months.
Yeah, correct, Dr. Sri. But if you have azoospermia, doctor, what time you repeat?
Immediately.
Yes,
As soon as
yeah, as soon as practical possible, yeah. And this from the update NICE guideline, undertake repeat confirm test ideally 3 months after the initial analysis to allow the time for cycle of the spermatozoa for formation. Yes, correct.
A 62-year-old woman present with dragging sensation and vaginal bulge. On examination, the cervix descends to the level of introitus on straining but doesn't protrude outside the vagina. What is the most likely diagnosis? Okay, prolapse.
Tells introitus. But does not protrude outside the vagina. What is the most?
second degree. Second degree.
Yeah.
Second degree?
Yes, second degree, Yeah, correct. Yes.
But it's leveled
Yeah.
up hard.
Yeah. And this is the one, doctor, let me stop here for a while because pelvic organ prolapse is very important, can come exam question. I remember February 20, I asked many exam question. Here you see the stage, your patient here telenteritis, yeah, it will be stage 2. And we have this stage 0, stage 1, stage 2, 3, and 4, very important. And you can see here, and after that will come, because the exam question, doctor, maybe they will give you picture like this, maybe picture like this, maybe they will give you table like this. In the table, it will not be draw like this. This is the one, you will be the one to draw. They will tell you in the scenario, what is the, because we have anterior vaginal wall and we have the posterior vaginal wall, we have the perineal body, and we have this one, they will tell you. After that, you will come to the scenario. We remember one. If stage 0, that means everything is in place. We have no uterine prolapse. If the patient comes stage 1, that means because we have anterior vaginal wall, it will come this A. And we have the proximal and we have the distal. And we have the posterior vaginal wall, they will give you by B. If above -1, that means you are stage 1. If you are between +1 and -1, +1 because out. 0 station, this is the introitus. 0 station and inner size, that means it is negative, you are not positive. If 0 and plus, that means 1. So if I will come to stage 2, it will be between -1 and +1. This one is stage 2. If we come to stage 3, that means out. That means the prolapse is out. So the leading edge, it will be more than 1 centimeter. But remember this point, because it can come exam question, total vaginal length is -2. If I will see the leading edge, because in the exam, they will give you the leading edge, and you will add 1 centimeter. If less than total vaginal length is -2, that means I am in stage 3. Because 0, 1, and 2, it is easy. The problem, when I come to differentiate between 3 and 4, the problem will come here. 3, if the leading edge more than 1 centimeter, but less than total vaginal, I will take, they will tell you in the scenario of the question, the total vaginal length. I will put like total vaginal length like 9 centimeter here. I will -2. It will give you 7. If they tell you the leading edge more than total vaginal length -2, it is less, you are in stage 3. But if they tell you the leading edge become, I put total vaginal length -2, 9 and -2, it will give me 7. If they tell you the leading edge is 8 and this 7, that means I'm stage 4. So here I can differentiate in stage 3 and 4 and stage 2 between -1 and +1. Stage 1 more than +1, stage 0 no prolapse. Everything is in place. Is it clear? Because I can't come exam question like before, and they will tell you the number. Because this one we have this anterior vaginal wall, and this one we have the posterior vaginal wall. They will give you a number. If positive, that means you are out the introitus. If negative, that means the introitus and inside. This is the anterior vaginal wall, and this is the posterior vaginal wall, and this is perineal body, and this is the genital hiatus, and sometimes they will give you the total vaginal length. From this one, you will calculate. If less than leading edge, less than total vaginal length minus 2, that means you're placing in stage 3. If the leading edge more than total vaginal length minus 2, like this 8 and this 7, that means you are in stage 4. Whatever exam question come, you can answer by picture, by shape, by scenario, and most of the time they will give you scenario in this one. Try roughly because they will give you paper in the exam. See what is the prolapse. If they tell you the anterior, that means I am cystocele. If they give me posterior more plus plus, that means I am rectocele. If they want to tell you the patient she had cystocele and rectocele, and they will ask you how to treat, that means the patient you will do the anterior repair and posterior repair, and after that you can decide. Is it clear, doctor? Yeah.
Yes.
Clear.
Yeah, and this is the one. If you have a stage 1, you have a stage 3, stage 4. This is the pelvic organ. Yes, doctor. Then,
An 80-year-old woman, an 80-year-old woman has complete uterine prolapse with the whole uterus outside the introitus. She is frail, medically unfit for major reconstructive surgery, and is no longer sexually active. She wants definitive treatment. What
she's
is the
8.
most appropriate?
Uh-huh.
See.
Yes.
Colpocolysis.
Yeah. Colpocolysis. This repeated exam question because I tell you, if they tell you the patient, most of the exam questions, they will tell you the patient she's 80 years old, elder, frail, medically unfit for major surgery. Yeah, this is the one, and she is not fit for because if I will do colbo suspension or colbo other surgery, see the patient she is not fit and she is old, and she had no desire of no longer sexually active. This is the most important because they will close this one. So the patient will be the colbicalysis, and we have this is the doctor colbicalysis is reserved for women who are not sexually active and who do not desire future coital activity because it precludes the penetrative sexual intercourse. The procedure is most commonly performed in women advanced age. And I tell you, most of the exam questions they will tell you 80 years, who frequently have limited cardiovascular function and cannot tolerate, because I remember one exam question from the steratology, they tell you she had big cardiac problems. The big problem, big morbidity, the patient she had severe morbidity, also she cannot go for colpocolysis. That time use ring. But if this patient, she had limited cardiovascular function, you will go for colpocolysis. And she had no desire for sexual. Yeah. Then,
Madam, can you please repeat? What did you say? That if a patient has a cardiac limitation, then we should go for?
the patient, if they tell you like this one only, you can see here, commonly performed in women with advanced age and who frequently have limited cardiovascular function. This is the one I will
Okay.
go for colpocolysis. But the one she had severe morbidity, also the colpocolysis you cannot do. That patient you can manage by surgery.
Okay.
Mhm. And then,
A 76-year-old woman present with symptomatic UV prolapse. She is medically fit but prefers conservative management. She remains sexually active and wants to avoid surgery. What is the most appropriate management?
She doesn't want surgery and she's sexually active. What will you do for her?
Pessary?
Yeah, ring
Pessary, ma'am.
bezeri. Yeah, ring bezeri. Yes, because she doesn't want surgery, the treatment, yeah, and she's sexually active, yeah. And this is the one vaginal bezeri are alternative treatment option for women with stage 2 till stage 4. All this patient, you can give them the bezeri. If the patient she has sexual activity, you will give her the ring bezeri. It will be important. You cannot give all this one because this one, yeah. So her ring bezeri will be a better option for her. Yes. This one. Then,
A 45-year-old woman has stress urinary incontinence. She leaks on coughing and exercise. Urine analysis is normal. She has completed 3 months of supervised pelvic floor muscle training with poor improvement and now wants definitive treatment. What is the most appropriate next management for this patient? Bladder.
what she had? She had stress urinary incontinence. She leak on cupping exercise. Urinary is normal. She had complete 3 months supervised pelvic floor muscle training with poor improvement. And now want definite treatment. What is the definite treatment of stress urinary incontinence?
Pulpose suspension.
Yeah.
Colposus.
Yeah, the definite treatment of stress incontinence is the colpoid suspension, but usually he will start by lifestyle modification, the pelvic floor muscle training. But if not work or not act, so the colpoid suspension will be better. And we have the option for treating stress urinary incontinence. The first one will be lifestyle change, including looking how much is the fluid you drink, losing the weight if you are overweight. Your continuous specialist can advise you. If after that the pelvic floor muscle for stress, it will be 3. For pelvic organ prolapse, it will be 4. And after that, we'll go for surgery. And the best it will be the colpo suspension. And we have the colpo suspension. We have rectus facial sling. In the guidelines, they tell this or this. They are not prioritize this or this. But if they you bring for you the rectus sling or colpo, better you will go with colpo suspension. It will be the correct option. And we have the retropubic mesh sling. I tell you the sling and all this complication, the mesh complications they doesn't like
دكتورة
that. Yeah,
دكتورة حسنية يعني firstly colpo suspension rather than
yeah,
facial
yeah.
rectus.
But yes, doctor, in the guidelines, they tell you this or this. But if you come in the exam, yeah, do colpo suspension, it will be the correct. تمام? Yeah.
Okay.
Okay.
A 58-year-old woman has urgency frequency nocturia and arch urinary incontinence. Urine analysis is negative. She completed bladder training for 6 weeks, but symptoms remains troublesome. What is the most appropriate next step for this patient?
What is your diagnosis? Nocturia and urgency incontinence. As a patient, she had bladder overactivity. The treatment, we usually, it will be, she completes the bladder training, because if I have urge, it will be the bladder training. If I have stress, it will come first by pelvic floor muscle training. That means she starts 6 weeks. She finishes this one. Still the patient symptomatic. The second line, because I tell you the bladder overactivity sometimes will be very refractory. So I need to be patient and go with the patient step by step. Now we finish the bladder drill. After the bladder drill, what will be treatment? And the patient 58 years, still consider young.
Oxybutynine.
Yeah.
Option
Yeah.
A.
Yeah.
Option
It
A.
will be, oxybutynine. But remember the elder patient, if they tell you the patient elder, if you remember the old recall, the patient will be the DR.FATH. Yeah. Yes, it will not be. She will not, because it will cross the blood-brain barrier. Yes, correct.
Madam, if we have the option of darifenacin and tolterodine in
The DR.FATH will come first. And if you have no DR.FATH, go to the other. But try
Okay.
to avoid oxybutyn. Yeah.
Okay.
And after that, I tell you, because refractory overactive bladder, this one, it is very important. So you'll go step by step. The first one, it will be bladder drain. The second thing, it will be the medicine. The third thing, it will be the surgery. And sometimes the patient after surgery also, it will not. But when you will try from the treatment to the surgery, before you will do surgery, here I will do urodynamic. Only here in overactive bladder, I will do urodynamic only here. If you remember the other indication, if you have stress incontinence mix or unclear, or before you will go surgery, or if the patient she had voiding dysfunction, all this for that indication. But here in the bladder overactivity, what time I will do? When I change, before I will go for surgery, I will do the definite treatment. Better I will do the urodynamic. Only indication here urodynamic if you finish the medical treatment and the patient not improve. Because all the surgery for this one, it is very invasive surgery. Yeah, so better you will confirm your diagnosis.
Okay.
29-year-old woman is undergoing diagnostic laparoscopy for chronic pelvic pain. She has no previous abdominal surgery and normal BMI. A closed varus entry is planned at the umbilicus. What is the safest direction for primary trocar insertion after adequate pneumoperitoneum?
You're doing laparoscopic diagnostic laparoscopy for this patient, and you will start by close by very needle entry, and after that you want to insert the primary trocar in the umbilicus. What is after adequate pneumoperitoneum? How it will be?
45.
C.
90 C.
90. Yeah. Yes, correct. 90 degree. Yes. Correct, this one. Stand at 90 degrees to the skin through the sinus part of the abdominal wall. Yeah, yes, correct. And this Veris needle, I can keep for you here, read in your time, because laparoscopy, it can come exam question as a open Hasson technique or close entry by Veris needle, or you can go direct by the trocar. Yes. I will keep for you here, you will read. Yes.
During laparoscopic adhesiolasis for severe endometriosis, the surgeon notices suspicious bubbling and fecal staining near a loop of bowel. The patient is stable. What is the most appropriate immediate next step for this patient?
The surgeon noticed suspicious blooding and fecal staining near the loop of bowel. That means you have bowel injury. If you have bowel injury and you are doing surgery, what you will do?
Patient is stable.
You have fecal staining near the loop.
D.
That means, senior help.
D.
Yeah, you will call for surgery, you will call for your senior, because you are here in this exam, you are ST5. And if I will here, I will inform my consultant, I will call the surgery, I will inform the circulating nurse. That means I have another bowel injury, I have complication, you need to inform more. But senior help, it will be, it will be. Yes. Appropriate surgeon, you want surgery to come with you here. Because delaying the cognition of bowel injury is associated with serious morbidity and may require major operative surgery. Yes. And this is the one, doctor, because I tell you, we have the bladder injury, and we have the bowel injury, and we have the ureteric injury. Repeated exam question. Who will start to play with my screen? Because this one I keep for you here because repeated exam question. And bladder injury, bowel injury, and ureter injury. They give you different, keep this in the group. Doctor, keep in the course group and journal group. It will help you to answer. Because the time also it is very important. If I am talking about the bowel injury, most of the time bowel injury it will come in the second day. If I will talk the ureteric injury, most of the time ureteric injury it can be 10 to 14 days. Sometimes it will be thermal injury. If I talk about the bladder injury, sometimes exam questions they will give you the scenario about, they will tell you the patient vomiting, abdominal distended, the bowel sound. This one will go, and usually it will be in the second day. The bleeding usually it will be in the first day, around 6 hours. Bladder injury usually it will be early, not like ureteric injury. And the presentation, because we have ureteric injury talk, it is very important. Yeah, so bladder injury, hematuria, abdominal distension, for both the serum creatinine, it will be high. Bowel injury, it will be different from the second day, the patient vomiting, distended, the patient more toxic. Ureteric injury, the patient, she is not recover. So keep this one, doctor, please keep in the course, in the group, anywhere. It will help you to answer the bowel injury, the ureteric injury, and the bladder injury.
Hello, all. Could anyone tell me if it's the voice breaking just for me or for everyone else?
There is no voice. Maybe there is prayer break for.
Oh, sure. No worries. Thank you. Also, are we doing Jan 2026 recalls?
I don't know. I am going to offer prayers. Once Madam will be there, we will be clear. Okay. Thank you.
Thank you.
Thank you.
No, doctor, I can hear you. There is some problem in the connection. We'll continue still there is time. Yes, Dr. Sana. Who is other? We'll continue. Yeah, we'll continue. Still, we'll continue. Yeah, this is the one I tell you there is some problem in the connection. I come back. Okay?
Madam, there will be no break for Maghrib prayer.
Because in my place still Maghrib. You can take break.
Hello, madam.
Rasana. Yes, you can hear me?
Yeah, I can hear you very well. I am just
Because,
asking.
take break, Dr. Sana, because in my place, Saudi Arabia, I am Riyadh, the prayer time not yet. I will continue with the other, you can join back. We'll take break.
Okay.
Yeah. Who?
Madam, may I know if it's 2026 recalls which we are doing at the moment? Jan?
No, this is a general discussion. We are going all through the module to highlight this one.
No worries,
But,
thank you.
but ask Dr. FATH, he'll do for you. I have no problem. Asking him to do the January, this one, the last report. Inshallah. All the best.
And this is a pregnant woman present with a suspected ovarian torsion. Conservative management is not appropriate. Laparoscopy is planned by an experienced laparoscopic surgeon. What is the most appropriate entry approach for this patient?
You have this patient pregnant 24 weeks, and she has suspected ovarian torsion, something we cannot avoid. And the patient in the second trimester, we can do surgery to this patient. Yeah, correct. But what is the, because if you remember, we have the TOG after 20, laparoscopic after 20. Yes, that TOG, it is very important, doctor, and they repeated many exam questions. Here they tell you 24 weeks. So what is the most appropriate entry approach for this patient?
Where are we gonna find it? Oh, look at it.
B.
Yes.
Yes, doctor, it will be the open entry. Please, other, close your mic, doctor. Yes, doctor, it is open entry, and it will be open Hassoon entry above the uterine fundus. Alternative, safe side, you can do the Palmer point, reduce the risk of uterine injury. Laparoscopic in pregnancy should be undertaken by appropriate experienced surgeon, not by anyone. We need experienced surgeon in the laparoscopic surgery, and this is the doctor talk. If not, you have not this one, I will post for you in the group after the session. We have laparoscopy in advanced pregnancy. And this table they bring many times. If you remember, I will read for you. Remember which one come in the exam question. They tell you have a top tip for laparoscopic and advanced pregnancy. Ensure experienced surgeon and anesthesia are present. Give antacid prophylaxis. Consider nasogastric tube. Apply, this is the one coming the recall before. Apply left lateral tilt to avoid aortocaval compression. Perform any change of position slowly. Consider using a Hasson entry. This is the one our recall now. Consider Palmer point. If you have no this one, you can choose the Palmer point. Use operating pressure 10 to 12. This exam question, if you remember, will not do the operating pressure, it will be less, not like regular. Auscultate the fetal heart, this recall, and this recall. Yes, you agree? 3 recall in from this table. Yeah. Yes, doctor. For all, no
Madam, can
voice.
you show?
Yeah, no voice for all. Because Dr.
Ma'am, can you show the question?
No, before no voice, but now it's coming.
Now you can
Why
hear
is
me.
it okay?
Now you can hear me well?
Yes.
Yeah, because Dr. Likan, he tell no voice. Yeah, it is okay. This is the one I tell you 3 exam question in this one. So this one, it will be from the important to advanced laparoscopic after 20 week. Yes, doctor.
Madam, can you show the previous question?
This
Previous
one?
question. This question, can you show us? Yeah, okay, thank you. Now next question.
Yeah, welcome. Yes. Yeah, if no this one, anything you have not, write in the group, we will post after the session, inshallah.
Inshallah. During open surgery for an adnexal mass, the surgeon need to gently hold the fallopian tube without crushing the tissue. Wow. Which instrument is most appropriate for holding the fallopian tube, Alice? Babcock.
Yeah, this for this
Like a
the
pen.
soft tissue here, like yes, the Babcock. I remember the picture. Please revise this one before you will go. Instrument. If not, let me post for you the picture before an instrument from the RCG. They can bring. I think they bring in February 20, and after that once. Maybe they will remember.
During an abdominal hysterectomy. During an abdominal hysterectomy for symptomatic fibroids, the surgeon needs to clamp the uterine pedicle securely before cutting and transfixing ligation. The instrument should provide a firm grip on the pedicle and reduce the risk of slippage. Which instrument is most appropriate for this?
Mhm.
Alice and Cocker for sale. Okay.
Mhm.
Babcock.
My scissor, needle holder.
Cocker.
كوخر D.
Kuchar in
Yeah,
our kuchar in our practice, but not kuchar because kuchar it is very tough instrument. Yeah, so you are only by what you if you remember the Alice in the bladder repair also in February 20. And if you remember the Alice also for rectus sheath also you can apply this one. Little wood also can for hini like lamb, hini clam.
إيه.
Yeah,
Unique.
clam. This is the picture from Waldo we call this one like that.
Okay.
Hmm.
A 24-year-old priming gravida at 16-week gestation reports significant household contact with her nephew, who developed chickenpox 2 days ago. She has no history of previous chickenpox on vaccination or vaccination. Varicella IgG is negative. She is asymptomatic. What is the most appropriate management?
Varicella. The patient is primary 16 week of gestation. Significant contact. What you will give here if you have, because this update in 24 partially update, varicella. So if you had significant contact and the patient 16 week, what you will do?
Oral acyclovir.
Oral acyclovir. If you remember before, we are giving
She is
varicella.
asymptomatic.
And yes, and this is the one you will do before because if the patient she is immune, if the patient not immune, if the patient not immune, you will give the patient here consider acyclovir from day 7 till the post exposure and give varicella zoster if there is contraindication to antiviral therapy or significant. So that means this is the one it will come first. Yes. Correct. Mm-hmm.
Oral acyclovir.
Mm. Mm-hmm. Yes, دكتورة سنة.
Okay. A 30-year-old woman present in spontaneous labor at 39-week gestation. She is known to be HIV positive but has poor antenatal attendance. Her latest HIV viral load is unknown. She is first time dilated with intact membrane and reassuring CTG. What is the most appropriate immediate intrapartum management for this patient at 39-week spontaneous labor?
He's HIV and you don't know the viral load because the viral load it will determine for us the delivery. We have HIV till update in 25. Now the patient here tonight you can you will give IV zidovudine, but the patient she will deliver normal. We have many argue for this question. The patient she can deliver normal if you don't know the viral load, or you can give her the zidovudine and the patient she can deliver normal. What is the best?
IV zidovudine and CS.
IV.
All of you.
IV zidovudine and
Normal delivery.
normal.
You'll give IV. Because if the patient she had no other indication of obstetrical, the patient only she's HIV will not go for cesarean. Give her treatment and go for normal delivery. But if the patient she had prolonged labor, give the treatment and go for cesarean. So the repeated exam questions they will tell you the patient she is HIV, like the patient she is asylum seeker, the patient she is refugee, the patient she is HIV positive, but no antenatal appointment, no antenatal follow-up. She come and tell you, you examine her, she's 4 centimeter in labor, and she tell you, doctor, I am tested positive for HIV. So here you will give treatment. You can deliver the patient normal, not indication for cesarean section alone. When the viral load is unknown in labor, urgent specialist input is required, and intravenous zidovudine during labor delivery is recommended to reduce the vertical transmission risk. Invasive fetal monitoring and procedures that increase the fetal blood exposure should be avoided unless it's essential. They are not tell you to deliver by cesarean section. and we recommend that women advise recommend the obstetric management in women plan for vaginal delivery should follow the same guideline as for those with HIV. Because the one we know the viral load less than 50, yeah, the patient is very high viral load, this is the one you will go for cesarean. The patient till 399 is considered to go for cesarean. Patient viral load less than 50, you can go for normal. Patient unknown, give zidovudine, try to deliver patient normal. If deliver short labor, okay. If prolonged labor, go for cesarean. Here from the update guidelines, they tell you the management of women, people present late pregnancy more than 28, not on the treatment. Pregnant woman more than 28 week. If yes, if the patient for both term and preterm labor, give oral dolutegravir 50 milligram plus imidricitabine 200 milligram, and to be preload the neonate. And preload the neonate, it will be oral rifampicin 200 milligram, and additional oral dose. Who is playing again? Doctor.
Sorry.
Yeah, and here if they tell you if a labor or spontaneous rupture in plan, no, start ART as soon as possible. Here, this is one, and here, Dr. Sana, you have this one management of untested women, people in labor. Sample for HIV testings taken and marked as urgent. If you remember, we have one exam question. They tell you will test for HIV, and some doctors they are confused. They tell the patient she will deliver. How I will test for HIV? Because we need to manage the baby. Yes, at the same time. If you have sample for it, HIV test, it can be taken and marked as urgent. And after that, maternity service telephone laboratory to reply the relevant clinical information. You will give them the result and you will call by phone. I send for you this patient suspected HIV or she tells she had HIV. They will tell you sample proceed immediately upon the receive. They will proceed the sample immediately, and after that they will tell you result. If the patient positive HIV, screening test. If yes, clinical laboratory staff verbally inform on-call obstetrician and pediatrician of professional result. Tell them the result is positive here. Consider treatment for mother, birthing parent, and neonate before confirmatory result available, especially if high likely to be true positive result. If no, therapy not required. Because here, if they tell you in the exam question, it can come like this, doctor. The patient, she came in labor and she tell you HIV. You will send the result and you will proceed. Give her the treatment and wait for the result. They will call you and will tell you the result is negative or the result is positive. And after that, you will proceed. Yeah.
Madam, it is for those whose HIV status is completely unknown, right? Or who we don't know if she's HIV positive or HIV
This
negative.
untested woman, people presenting in labor, the patient she is not
Yeah.
testing this one. This is the table.
Yeah.
But the other exam question, if they tell you the patient she is came positive and she doesn't know the viral load, this is the one also you can send for the test, give her the treatment, and you can deliver the patient normal. If not prolonged labor, you can try for normal. Prolonged labor, give the treatment and go for cesarean.
Okay. Okay, thank you.
Okay, welcome. Yeah.
Okay, a 34-year-old woman at 18-week gestation present with breast lump, triple assessment confirmed invasive ductal carcinoma. There is no evidence of metastatic disease. She wishes to continue the pregnancy. What is the most appropriate management for this patient? 18-week gestation.
Breast cancer also update, yeah. GTG update. Then the patient she had invasive ductal carcinoma and 18 week after the first this one first trimester. That means it is okay. The patient she had cancer. What I will do?
Surgery. Wow.
Yeah, surgery. Yeah, we will give surgery and chemotherapy. In the second trimester, the patient like 18 week like this, I can go for surgery. Yeah, it is okay. Go for surgery now, and the patient she can receive chemotherapy, and you will delay the definite treatment. Yeah, later. Yes.
Okay.
And this is your recommendation here in the surgery. Surgical choice should be the same for non-pregnant women. With the exception that reconstruction it cannot be done. You will do surgery, no problem. The second trimester. Then.
A 29-year-old woman present with offensive frothy yellow-green vaginal discharge. vulvar soreness, dyspareunia. Examination shows a strawberry cervix, not confirmed trichomonas vaginalis. She is not pregnant. What is the most appropriate treatment? Metronidazole.
Metronidazole.
Yeah, yeah.
Metronidazole.
Yeah. Metronidazole. And yeah, trichomonas treated with metronidazole, and sexual partner should be treated and avoid intercourse for 7 days. Yes.
A 24-year-old woman at 14-week gestation has positive antenatal syphilis screening test. Okay, she has no symptoms. There is no previous documented treatment. What is the most appropriate next step at 14-week gestation?
Right, in your note, don't forget the syphilis. Yes. At the end, you will tell me, Husni will say all guideline, it is important. You read the syphilis. It will come example, Sham. They like the syphilis. Yes? I am correct or no?
Yes, ma'am.
Yeah. Now she's 14-week gestation and she have positive antenatal syphilis screening test. She had no symptom. But because usually this from the routine test, you will do the syphilis and the result come positive. What you will do? If this is your patient.
Urgent GOM referral.
Yeah. You will refer her. Yes. Yes. And this is antenatal care, what you will do. Yes. Here screening team specialist midwife, the gum service, pediatric, neonate, or obstetrician. This is the team they will be. But if they tell you prompt engagement with the gum. Yes. And here collect the information to support onward referral to gum. Yeah. This from the syphilis.
A 62-year-old woman present with severe vulval itching and dyspareunia. Examination showed thin white plaques, fissuring, and loss of vulval orchidity. There is no suspicion, ulcer, or mass. What is the most appropriate first-line treatment? Clobetasol.
This lichen sclerosis. Lichen sclerosis update where? 26 or 25? Yeah, we have this update guideline. Lichen sclerosis. I suspected before because lichen sclerosis it can be in the adolescent, it can be in the reproductive age, and the patient it can be in postmenopausal. Yeah. Now they bring this one the lichen sclerosis in pregnancy. Please go there is table, there is algorithm in this one. Read it because all the question before they ask about the lichen sclerosis, most of the time, postmenopausal woman. They tell you the patient 58, 57, and she came with this fissuring and loss of architecture. But now, if this guideline come, because it come lichen sclerosis in pregnancy, I want you to go through it. Please. I expect one question to come from it. The treatment and all the it is important, but you see the antenatal follow-up, the treatment and postnatal and breastfeeding, all it is mentioned there, very important. But yeah, correct the treatment of this one, it will be the clobetazole. And this one sometime because they will bring for lichen sclerosis. Before, if you remember, I tell you, they bring from the 2017, most of the picture, this one. But this one from the update guideline, they can bring this picture and this about the treatment, half fingertip showing the amount of topical steroid to be applied, this one. And here, while ultra-potent topical steroid are undoubtedly the treatment of choice of lichen sclerosis, there is some evidence of use of calcineurin inhibitor, tacrolimus, and this one. But the first line treatment, it will be the potent steroid, the potent clobetazole. Yes.
A 68-year-old woman is diagnosed with vulval carcinoma, vulvar squamous cell CA. The tumor is confined to vulva, measures 1.5 cm, and stromal invasion is 0.8 mm. There is no nodal or distant metastasis. What is FIGO stage of this cancer for vulvar carcinoma?
Vulval cancer, we mentioned, will come with PA questions. They will tell you
Stromal
stage.
invasion is 0.8.
Which stage?
1A.
Yeah, will be
It's
1A because
1A.
less than 1 and less than 2. This is from the easy staging for the vulval cancer. Yeah, keep for you this one, you will treat. And remember the punch biopsy and excisional biopsy for vulval cancer. It is not incisional.
A 59-year-old woman
Punch.
present with persistent. A 59-year-old woman present with persistent vagina vulval itching and a new irregular ulcerated vulval lesion. Symptoms have not improved with topical treatment. Vulvar cancer is suspected. What is the most appropriate diagnostic procedure for this patient?
This is one I am asking because repeat it. You will do punch biopsy, you will do incisional biopsy, or you will do excisional biopsy. Which one is correct?
Punch biopsy is better.
Yeah, and punch biopsy from the incisional or excisional?
Incision.
Yeah, incisional. You will not do
Incisional.
Yeah, incisional. You will take part, you will not take all. Because if I do excisional, I will take all. This it will be a problem if I came later, I want to take this one biopsy again. And this one is the vulval cancer. We have the TOG and we have the vulval cancer which is updated in 25. And this is the BGCS. Also, it is important to read the doctor because this one from the BGS, they are very clear, they are very arranged, not like the FIGO. So they tell you, woman, if you have woman suspicious should be referred to rapid access. And suspicious vulval lesion should ideally be sampled with a punch or wedge. And biopsy and excisional biopsy avoided until diagnosis is made. Don't do excisional, it is incisional. And if they tell you punch or wedge, that means the correct answer. And this is the key punch biopsy from the old dog, and this is from the BGCS because they will tell you the follow-up. If the patient she had high risk, the patient will do punch or wedge biopsy, and after that you will refer the patient because high risk of malignancy like in sclerosis, this one, or vulval cancer, the risk, yes, high. Yes.
A 25-week pregnant woman requests termination of pregnancy because of the social and financial difficulties. There are no fetal abnormalities and no serious risk to her life or long-term health. What is the most appropriate legal ground clause?
25 week. And she
Not
wants
a legal ground for abortion after 24 weeks.
Yeah, correct. After this one, cannot be. But less than this one for social background, yeah, it can be classy. Yes, you are correct. I give for you this way. Abortion Act 1967 it is very important because after 25 you will not do. Yeah.
Okay. A 35-week pregnant woman has amniocentesis confirming trisomy 18 fetal medicine counseling confirm a high likelihood of severe disability. If the baby is born, she requests termination of pregnancy. What is the most appropriate legal ground?
For abnormality, congenital abnormality, it will be under which class here?
E,
Yeah,
I think.
Yeah, it is E. Yeah, correct. Because if you have, if she has another baby is down and she doesn't want to get this baby, she want to termination. D for social problem for baby, it will be D. For congenital anomaly, it will be E. For social problem, patient herself less than 24, it will be C. Any emergency, it B, and this emergency, it will be B. Any grave or risk to the mother, it will be F. Yeah, correct. Then.
A 24-year-old woman taking a 30 microgram ethinyl estradiol combined oral contraceptive pill forgets to active pill in the second week of packet. She had taken all pills correctly in the previous 7 days and had unprotected intercourse 3 days ago. What is the most appropriate advice?
She missed 2 pills in the second week because the week here also it is important. Week 1, 2, and 3, and the last week. In the first week, this is the most important. If the patient she missed pill here, 2 pills, she need in the COC emergency contraception. In the second week, if she missed 2 pills, need emergency contraception, or it will be maintained by the first week because if she received correctly. Here, what you will do in the second week and the first one she received correctly.
She will take the last pill and no additional, no emergency contraception required.
Yeah, no, yes, correct. But she need extra
Additional.
additional, yes. Yes, you are correct. Use condom for 7 days. No need because the first days maintain the second week, and we have here emergency contraception. It is not required. Keep this one in front of you. If they tell you 1 pill, emergency not required. If you have 2 pill in the first week or the second week, if you have 2 or more missed pill. Yes, more than 70 since the last bill in the current back. Yeah, right.
A 32-year-old woman attend for a routine copper IUD check. She is asymptomatic, but the IUD tears are not visible on the speculum examination. She has no pelvic pain or abnormal bleeding. What is the most appropriate next investigation after excluding pregnancy?
Let's repeat record, yeah. She had IUCB, the thread not visible, the patient is stable. What you will do?
Ultrasound?
Yeah, you'll do ultrasound. Yes, you'll do ultrasound and you'll go here. If the patient, you arrange ultrasound, if ultrasound shows IUC in situ, leave in situ until due to be removed and don't attempt to retrieve the thread unless removal required. In ultrasound, if you cannot see in situ, request, if the second question they ask you, here ask you ultrasound. The second will be X-ray. If IUC not seen, maybe expel because the patient is stable. If IUC seen, refer to gynecology for laparoscopic removal. Yeah, correct.
A 28-year-old woman had unprotected sexual intercourse 4 days ago. She is mid-cycle, which is the most effective emergency contraception and has no contraindication to intrauterine contraception. What is the best option for this patient?
In the middle of the cycle.
Copper IUCD.
Yeah. All the time,
Yeah.
if you have, you are left by, yeah, it will be cover IUCD because the hormonal after this one, it will not act. Yes. Correct.
A 26-year-old woman taking the COC is started on carbamazepine for epilepsy. She wants reliable contraception and does not want pregnancy for several years. What is the most appropriate contraceptive advice for this patient on carbamazepine already?
Enzyme the user. And she doesn't reliable does not want pregnancy. Yeah. So
Switch to copper ID.
yeah, cover also. Yes. Because this is your option here. The progesterone only injectable, the Demba or Marina or the copper IUD. And the best anytime if you have the copper IUD in the option, it will be the correct option.
A consultant is teaching trainees how to manage postpartum hemorrhage. The trainees already know the basic steps. The consultant asks them to compare different cases, identify key features, refine their mental framework and apply it to more complex scenarios. What is the most appropriate teaching method for this? Mini appraisal.
Schema refinement.
Yeah. Schema refinement. Because you are basic and you apply the clinical. If basic only, it will be schema activation. If basic with clinical, it will be schema refinement. Yes. Yes, correct. The teaching. Yes, we have 3 questions.
A senior registrar perform an emergency C-section. The consultant observes her communication with anesthetist, awareness of the clinical situation. What is the assessment tool is most appropriate?
Knots.
Yeah. Outside the surgery, it will be the knots. Yeah. The situation awareness, decision making, communication, and teamwork, leadership, and yes. And this is what is the knot. They like the knot. Yeah.
A maternity unit plans to introduce a new outpatient hysteroscopy service. Before starting, the team identifies possible hazards, estimates their likelihood and impact, and develop action to reduce harm. What is the process called?
Risk assessment.
Yeah. This risk assessment.
Yeah.
Yes. To reduce the harm. Yeah. From the clinical governance, risk assessment is the process of identifying hazard, estimating the risk, and introducing the control measure to reduce the chance of patient harm. We have this clinical governance, we have the clinical effectiveness, information, risk management, from the important component from the clinical governance. And here we have the risk management. You will identify, you analyze, you action, you monitor, you control. If you have risk you have any problem. And this is the basic question addressed by the risk management. It will be the question, what could go if you have risk identification, and what are the change if it is going wrong, or what would be the impact. It will be risk analysis, and what can we do to minimize the chance of the happening or to mitigate the damage. So the risk treatment and what can be learned from the thing, it will be risk control and sharing and learning. This risk control, and here it will be the same. Then
a department compares its rate of giving antenatal corticosteroid before preterm birth. After identifying poor compliance, the team introduces a checklist and repeats the measurement 6 months later. What is the process?
If you have problem in your hospital, they have problem in the preterm, and for giving the antenatal corticosteroid, you address this problem, and later the measurement 6 months later. So what is here the process? What you-
Audit.
Yeah, yeah, audit. Yeah,
Audit.
yeah, it is audit. Yes. Yeah, we have in the audit, we have the file cycle. The first one, you will identify the problem or issue, and after that, you will set your criteria and standard. It will be your GTG or NICE recommendation, and after that, you make change, observe your practice, you do data collection, compare the performance with the criteria, and implementing of change. Most of the exam questions, I will tell you the implementing and change, and the last one, it will be re-audit.
A 38-year-old woman with symptomatic fibrosis is counseled about hysterectomy. She understands the diagnosis, treatment option, risk, benefit, and alternative. She declines surgery because she wishes to preserve the uterus. Despite the doctor believes surgery is the best option, which ethical principle is most relevant? Beneficial.
Autonomy.
Her autonomy, yeah. Yeah, her autonomy,
Person.
yeah. She understands everything and she refuses her autonomy. She doesn't want. Yeah. Yeah. Correct.
A woman is being consented for a diagnostic laparoscopy. You explain that the risk of serious complication is approximately 2 in 1,000. How should this risk be described? 2 in 1,000.
Mm. Mm-hmm.
Rare.
Uncommon.
Yeah, yeah.
Oh, okay.
Yeah, yeah. It is uncommon. Yes, correct, doctor. Uh-huh.
A 62-year-old woman with advanced ovarian cancer is admitted unconscious with sepsis. She lacks capacity. Her records include a clarity valid and applicable advance decision refusing intensive care treatment. In this situation, what is the most appropriate action for this patient who lacks capacity?
She had advanced decision refusing intensive care treatment. Uh-huh. Now she came with advanced unconscious with sepsis. What you will follow here?
Can you help? Yeah, I got you.
Follow
I'm
the
fine.
advanced position.
Yes.
Let's Taylor Swift.
Follow available actions.
Yeah, because she had advance in the decision before. Capacity is decision specific and time specific. When adult, she had valid applicable advanced decision. So you will follow. Yeah, you remember this one. If the patient she had advanced directive in place, you will follow. If the patient she had lasting more of autonomy, this is you will follow. If the patient she had big problem, if she had very emergency, you will act as a doctor for best interest. But our patient here, she had advanced directive in place before she became unconscious. So you'll follow.
A 15-year-old girl attends a contraception clinic requesting the combined OCP. She doesn't want her parents informed. She appears mature and understands the advice, risks, benefits, and consequences. There are no safeguard concerns. What is the most appropriate next step for this patient who understands? Assess competence.
Yeah, she's 15 years. If she competence, you will prescribe for her contraception, no problem. And contraception, the first one assess Glick competence. The patient she is competent, she is fine. If the patient she is competent, you will prescribe for her the treatment by the contraception by Fraser guideline. Her competence by Glick competence. Yes.
A 42-year-old woman present with a leakage of urine on coughing, sneezing, and exercise. She has no urgency, no nocturia, no recurrent UTI, and no pelvic organ prolapse. Urine dipstick is negative. Examination confirms stress urine incontinence. What is the most appropriate first-line treatment for this patient? So PFMT, pelvic floor.
Yeah, pelvic floor muscle training, the first line. And after that, after
See.
pelvic, for stress, it will be the surgery. After this one from the conservative, your initial treatment, present voiding dysfunction or symptomatic pelvic organ prolapse. If in the scenario in the exam, they tell you the patient she had pelvic organ prolapse, it will be referred because it will affect her treatment. The patient she had conservative treatment, the first I will diagnose it. The patient she is stress incontinence, it will be pelvic floor muscle, it will be number one. Education, consider pharmacological treatment. If you remember, we'll see the patient what is her dominant symptom. The dominant symptom, it will be treated first, if you remember the old recall. The patient, she had early incontinence. The first one, you will review the caffeine. She's taking more. The bladder retraining, it will be the treatment. And after that, the antimuscarinic. And after that, if not respond to this one, you will go for surgery. The patient, she had mixed urinary incontinence. You review the caffeine intake, bladder retraining, pelvic floor. I tell you in the exam side times, they will tell you the bladder retraining and pelvic floor together because the patient, she is mixed. But see which dominant symptom to the patient, or ask the patient what is the buzzer. So in the exam, if they tell you the dominant symptom to the patient, it is overactive the bladder, it will be the bladder retraining. If you see the dominant symptom, it will be pelvic floor. The patient, she had stress mainly, it will be the pelvic floor muscle training. Treatment success, complete this one and maintain. If not, refer the patient to secondary care. They will do more in the investigation, will do the urodynamic. The treatment of overactive bladder, it will be, if you are confused, you cannot diagnose this one, do the bladder diary. It will tell you which is which. The patient, she had, the patient, she had bladder, overactive bladder, or the patient, she had stress, or the patient, she had mix. If you have stress, it will be the same. The first line treatment, it will be floor muscle training, digital assess the pelvic floor muscle, pelvic floor to consider 8 contractions 3 times per day. If beneficial, continue. Don't routinely advise electrical stimulation. Lifestyle intervention, modifies the fluid intake, weight loss, and constipation management if the patient, she had acute pain. Pure overactive bladder, you will do the bladder drill, and after that, if the patient, she is fine, not responding, go for the medical treatment. The patient not responding, first you will go, not recommended, do the urodynamic. Ultrasound except to assess if she had residual, this one, because it will be assessed by ultrasound, not by catheter. Routine use of pad, no. Cystoscopy, it can be. Mixed urinary determines the treatment based on the predominant. Stress urinary as the dominant symptom. If they tell you mixed, determine the predominant symptom of the patient and treat the patient. Allahu Akbar.
A 55-year-old woman is referred with urinary leakage. She reports leakage on coughing and sneezing, but also troublesome urgency and urine incontinence. Examination showed demonstrable stress leakage. She is considering surgery for SUI. What is the most appropriate next investigation before surgery?
Yeah. If diagnosis here, because the patient refer with urinary leakage, she report leakage and coughing, sneezing, that means stress, but also troublesome urgency and urge incontinence. That means the patient, she had stress incontinence. If the patient, she is mixed urinary incontinence and clear for you it is mixed urinary incontinence, okay, no need for any investigation here. But if you remember the indication of the stress urinary incontinence, if it is unclear, or if the patient, she had voiding dysfunction, or if the patient, she will go for surgery before surgery, or if the patient, she had voiding difficulty. This is the one I will do the urodynamic. Here, the patient, she had mixed urinary incontinence.
Yeah.
So, madam, here the patient will undergo the urodynamic studies, right?
If here, because the question, if mixed urinary incontinence, if mix and it is clear for you, it is mix, okay. If mix and this one, it is not clear, you cannot say this patient, she had stress, or this patient, she had overactive bladder, so better, yeah, from the indication of urodynamic, yes. But if they ask
Okay.
you diagnosis here, it will be the mixed urinary incontinence. Yeah, remember the 4 indication of urodynamic, don't forget. And of the overactive bladder, before you will go for invasive treatment, also do urodynamic. Only indication of this one. And if the other all 4 indications, that means you will do, if the patient is specialist, will go for surgeries, do the urodynamic before this one. Yes.
A 31-year-old primary gravida. Should I read?
Yeah.
Okay. A 31-year-old primary gravida at 32-week present with a reduced fetal movement since the morning. There is no abdominal pain, bleeding, or rupture of the membrane. Fundal height is appropriate for the gestation, and maternal observation are normal. What is the most appropriate initial assessment for this patient with reduced fetal movement since morning?
Yeah, we have the GTG reduced fetal movement, that is update. I think the last one update, yeah. So the patient here, 32 week and present with reduced fetal movement since morning. She had no other risk factor, no abdominal pain, no rupture, no problem. In the fundal height, she had no IUGR also. We have no any risk. And primary, her first baby. That means she had no risk of stillbirth, no problem before her first baby. And she's young patient, 31 years old. When the patient, she will present it to you at more than 28 weeks, and she tell you she had reduced fetal movement, what you will do?
CTG.
CTG.
Yeah, CTG.
CTG.
Yeah, CTG more than 28 weeks. Do CTG to this patient and go through this recommendation. If the patient she had any reduced fetal movement to come to this one. And here, let us go through it. If woman present with reduced fetal movement in the community setting with no what facility to auscultate the fetal heart, the woman should be immediately referred to their maternity unit for auscultation. And when women present with reduced fetal movement in the community or hospital setting, attempt to should be made on auscultate to the fetal heart using a handheld Doppler device to exclude fetal death. Clinical assessment of women with reduced should include assessment of fetal size by measuring symphysis fundal height, and if the patient have blood pressure and urine analysis. Yeah, come to this part. What is the role of cardiotocography? In women with reduced fetal movement after viability has been confirmed, arranging should be made for them to have a computerized cardiotocography to exclude acute fetal compromise. And if the pregnancy is 26 plus 6 weeks of gestation or late, for recommendation prior to this gestation. That mean here, better will do the CTG. The patient 31 and she comes with this, I will do CTG. The patient she had problem or no. And this is their recommendation. If the patient she come with decrease fetal movement, let us do together. Attend with presentation reduce fetal movement and more than 28 week. Our patient here more than 28 week. If history does not confirm reduced fetal movement, offer auscultation fetal heart, routine antenatal assessment, give advice regarding further episode of reduced fetal movement, and if unsure whether the fetal movement are reduced, focus on the fetal movement for 2 hours. You will tell the patient, and if they do not feel more than 10 movement in 2 hours, contact the healthcare provider. Yeah, here the patient will come here. But if history confirm reduced fetal movement, the patient should tell you, still I cannot feel the movement of my baby. Sculptate the patient with the hand held to confirm the fetal viability. If fetal present on the auscultation, do the CTG to exclude acute fetal compromise. If normal fetal heart rate better in here, consider continue to have reduced fetal. If the patient she is fine here and she perception of fetal movement resolve and no risk factor or FGR or stillbirth or patient she is primary, no FGR, no stillbirth, everything is good, reassure and give advice regarding further episode of reduced fetal movement the patient to come back. But if you do normal fetal heart rate bettering, continue to have reduced fetal movement. Already the patient she had risk factor for FGR or stillbirth. You will do ultrasound for estimated fetal weight, you will do amniotic fluid, you will do the volume, umbilical artery, Doppler. If normal scan, also the patient reassure and tell her if you have another decreased fetal movement, come back. And here, if the ultrasound abnormality detected on scan, the patient will come here. Or if CTG abnormality, suspicion of pathological heart rate, manager as unit protocol. That means if do CTG is abnormal. Or the patient she had problem here or abnormality detect I did scan for her it is abnormal, also it will come here. I will manage the patient as protocol. If the patient is high risk, maybe if the patient extensional age is good, maybe I will induce and manage the patient. But here, if I did auscultation by handheld Doppler to confirm fetal viability, fetal heart not present on auscultation. If present, I will go this direction and according to the risk. If not present, I suspect the patient she had intrauterine fetal death. I will do immediate ultrasound to exclude diagnose IUFT. And here ultrasound is very important. Also this record question. If you cannot feel, do immediately ultrasound. Yes, here is also exam question. Yeah. Then.
A 28-year-old woman attended the booking clinic at 11 plus 5 weeks. Ultrasound confirmed in pregnancy. The sonographer needs to estimate gestational age and determine chorionicity and immunity. What is the most appropriate investigation for this patient?
What I will do? to determine the
First
pregnancy.
trimester ultrasound 11 to 14 weeks.
Yeah. Before 14 days, I want to
Yeah.
determine, because later, if it is not done early, you cannot do. And if you cannot determine this one, she had dye or monochronic, this one, you will take the picture and you will form as a senior, or you can save the picture till, because later it cannot be diagnosed. So the first
Yes.
trimester, yeah, it will tell you. Nice recommend the first trimester before 14 week to determine the chronicity, because if you have T sign or lambda sign, and the earliest time to determine the chronicity between 6 to 8 weeks. But if they ask you, it will be this time, 10 to 13, before 14. Yeah, the best time. And this is the lambda sign, and this is the T sign for monomer.
A 26-year-old Rh negative woman, non-sensitized woman at 24 weeks, has a minor abdominal trauma after road traffic accident. There is no vaginal bleeding and fetus is alive. What is the most appropriate anti-D management for this patient?
She's Rh negative, and she had trauma 24 weeks. That means more than 20. What you will do here?
500 international unit anti-D plus fetal-maternal hemorrhage test.
Yeah, correct, because more than 20. Yeah, and I will keep for you this one here. Yes, doctor.
A new screening test for cervical disease is introduced among women with positive test result. The examiner wants to know the proportion who truly have the disease. Which statistical measure is being described for this positive
Positive prediction value.
Yeah.
positive predictive value?
Yeah. It's a positive predictive value. And here, doctor, because in the exam questions, they will ask you, sometimes they will give you the scenario and they will ask you to make the table. Sometimes they will give you the table ready. If they give you the table ready, it is good and fine. If they not give you the table ready, yeah, keep this one, doctor. So he will do. He will do the true positive, false positive, false negative, true positive from the scenario. And after that, you will answer this one. Because in the exam, they can ask you about the sensitivity, specificity. I will keep for you here in the session. And the sensitivity, number of the true positive, number of the true positive, plus number of the false negative.
Can you show the previous slide? Previous slide for sensitivity.
This one?
Yes, thank you.
Yeah.
Yes. Okay.
Take a picture, keep in the group. It will help you to make your this table. And this is the one specificity, number of the true negative, divide by number of false positive plus number of true negative. And here positive predictive value. What is the positive? Proportion of patient with a positive test result who are correctly diagnosed. So we'll go true positive, divide by true positive, plus false positive result, negative predictive value, proportion of patient with negative test result that are correctly diagnosed will be true negative, divide by true negative plus false negative result. And this one, please keep in the group, it will help you. If I want, because I tell you, no need to save this table. If I want, if they are not in the scenario in the exam, they cannot give me, I will make the table. And after the sensitivity, doctor, go this direction, I tell you. This direction, how? I will true positive, divide by, I will go this direction, yeah. So true positive, divide by true positive plus false negative. If I want to calculate the sensitivity equation, it will be that I go this direction, the sensitivity. So it will be true negative, divide by true negative plus false positive, because this is my direction. If I want to do the positive predictive value, it will be true positive. Here also this direction, true positive plus false positive result, it will give you the positive. If I want to do negative, I will go this direction. So it will be true negative, divide by true negative plus. So the negative, this direction. Positive predictive value, this direction. Sensitivity from up to down. Specificity from down to up. Keep this one, it will help you about sensitivity, specificity, positive predictive value, and negative predictive value.
A randomized trial compares a new treatment for heavy menstrual bleeding with standard care. The study concludes that there is no significant difference between the two treatments. However, in reality, the new treatment is effective, but the study was too small to detect the difference. Which error has occurred? Type 2 error.
Yeah, type 2 error, yes. Most of the exams, they will ask you about the type 2 error. Yeah, we have type 1 alpha. This is the one also known as error of the first kind. When you reject the null hypothesis when it is true, it will give you type 1 error. And when you will accept when it is false, it will give you type 2 error. And this is the one, doctor, it will help you. When? Because here you see the reject the null. And here null is false. And here is null is true. If I reject the null hypothesis, yes, and the null hypothesis is false, false and I reject. It is a good decision. No problem, yeah, here, yeah. And if they reject the null hypothesis and actually the null hypothesis is true, that means I commit error. It will be type 1 error. It will be the false result. If I fail to reject, doctor, that means I accept. If I fail to reject, I accept. That means a null hypothesis, I accept and it is false. Here it will be type 2 error. If I fail to reject, that means I accept and it is actually true, it will be good decision. So to understand type 1 and type 2 error, I think this is will be better. Yeah. Yes. Understand?
Yes.
Yeah. Keep this one, it will help you. And then
Okay. Researchers follow a group of pregnant women who smoke and a group who do not smoke from early pregnancy until delivery. They compare the incidence of fetal growth restriction between the two groups with smoke and unsmoke. Which study design is this? Case cohort study.
because in the study we have
Cohort
experimented.
study.
Yeah, it will be. Yeah. Yes,
Cohort study?
yeah, it is cohort study because you are comparing. If because we have this experimental, it will be the only randomized control trial, and all the other it will be observational. We have the case control, we have the cohort, we have cross sectional, and we have this one. Here it is cohort because if I start by the disease patient, it will be the case control because I will go back and it will be retrospective. If I will start from early pregnancy and I will go through all this 9 months and I will compare the patient they have smoking or the patient not smoking in this one, in this group, and after that I will see which one it will be affected by growth restriction. That means it will be cohort. That means the patient exposed to the risk and the patient not exposed to the risk, and I will take time and I will get the result. So it will be cohort. Yeah. But if case control, he will take the risk. You will start the patient she had disease, and after that you will see the risk during this time. Yeah.
Okay.
And this is the type of study. We have an experimental observational study. It will be descriptive analytic, or you have individual based, it will be descriptive analytic, and we have the observation. This is the question it will come in the exam, this one. The cohort, the most repeated exam question. The case control, it will be retrospective, it will be less, and cross-section study preference of study. The incidence, you go with the cohort. The preference, you go with the cross-section, if you remember July 21. Yeah, if cost control, it will be because from the history, it will be biased, not from the good study. The cohort from the good study and the randomized control, because this non-experimental, only observational study. And here we have the experimental intervention study. If we have randomized, it will be control trial, or if you have non-randomized experimental. Yeah, most of the exam, it will come non-randomized control trial or cohort or case control. This one in the casualty, the randomized from the good study and cohort from the good study, and after that cross-section, and the last one, it will be the case control. Yeah. And then,
A 26-year-old primary gravidia ate 18 plus 4-week books for antenatal care. She was born in Somalia. She reports dyspareunia and a low urine stream. On vulval inspection image provided, the labia are fused, creating a covering seal with only small opening for urine and menstrual flow. The vaginal introitus is markedly narrowed and vaginal examination is difficult. A bedside ultrasound confirms a singleton pregnancy with normal anatomy. She wishes to plan a vaginal birth. What is the most appropriate management for this FGM patient?
she had creating covering seals. That mean which grade in the grade 3, yeah. And the patient she is 18 weeks plus 4 days. If you want to do defibrillation in the antenatal, what time it will be done?
At 20 weeks.
Yeah, it will be done at 20 week. If not done at 20 week, it will be in the first stage of labor if the patient epidural. If not done in the first stage of labor, it will be just before crowning, if you remember the old record. If not done, yeah, it will be during the cesarean section. If not done, the patient she will come for follow-up. It will be, yeah, this is the one. Yeah, and this is, yes. I want to pray,
A
but I
woman
think
with
it's a
a
ridiculous
woman with
question.
female genital
Mm,
mutilation.
mm. Yeah.
A woman with female genital mutilation type 3 has undergone a planned C-section. During the surgery, intrapartum defibrillation was not performed. She is now recovering on postnatal ward. What is the most appropriate next step regarding defibrillation? Refer to FGM clinic.
Read the option, or maybe you'll change your mind.
Okay, refer to perform defibrillation following delivery with consent.
Yeah, yeah. It will be C. Yeah. And this is the one. Yeah. A woman whose planned defibrillation was not performed because of delivery by cesarean section should have a follow-up in gynecological outpatient or FGM clinic so that defibrillation can be offered before subsequent pregnancy. Yeah. And here, this is the time, an antenatal, first stage of labor at delivery, perioperatively. If cesarean section undertaken, the intrapartum deflation has been planned. The inflation may be undertaken following delivery with consent. Yeah. Yes. Then.
A woman presents 4 days after oocyte retrieval with abdominal distension, right liposomas, nausea, and vomiting. Ultrasound shows enlarged ovaries and ascites. What is the most likely diagnosis? Oocytes, madam.
Yeah. Because this one from the update GTG. Yeah. And they will tell you clear scenario. In the scenario in the exam, they will tell you all the point you want, the ultrasound finding and the patient clinical condition and the examination. The one I want you to learn from this session, you will go through this one because we have ovarian hyperstimulation update, the GTG, and we have the ovarian stimulation update. This one took before this one, but if we have GTG and took, so will depend only in the GTG. And this is a mild, moderate, severe, go through it and how you will treat the patient. It can come exam question. Because from recent updates, the last one update guideline. And yes, doctor, we are here today. We are saving life, improving mother care. This is our aim to study for RSWG or to pass this exam. And this our target. This is smiling and we need the baby to be like this. Yes, doctor. And thank you very much for attendance and all the best in your exam.
Thank you, madam.
Thank you, doctor. Thank you.
Bye.
Thank you so much. Thank you, madam.
شكرا. Any comment, any help, anything, Arabic, English, any language, what do you want? شكرا. يلا. Say, what do you want, anything, tell me. Any help, I am here to help. Any question from the session, we are here for you.
Bye.
Yes.
Bye.
Yes, doctor. Any comment or I will close the session? You want anything? Tell me. We are here for you. Only 10 days. And I used to help you in this RCOG exam and I will continue to help. I will not stop. If you want anything, you can ask in the group. If you want any material.
Solve 20.
When to continue, Dr. Husnia?
Yes, doctor. What you ask?
What's the next session?
I will, the one they are doing today, I will ask you because we have only in the course, we have this July 25 and we have January 26. Yeah, if you want to join the discussion, I will tell you, message me. We will be there, inshallah, together. During this week, we'll finish. We're about to
You
finish.
have to solve. You
Yeah.
have to solve with just 2026 JN exam, please.
Send the message to Dr. Fatih and for me, send for me message. You will join with me. No worries. Okay. Yeah. Yes, doctor.
Ma'am, this session was only one day or it will continue for other days as well?
Because this is the revision for, this is actually for the course for Dr. Fateh. But because we want to involve you, it is important. We have no revision. We have only remaining in the course. Yeah, my friend in the course, Dr. Leikan, Dr. Nuh, Dr. Anabila, Dr. Win, all there. We are remaining only by this one, January 26 and July 25. Inshallah, we'll do. Because we have 10 days. After that, the last 1 week, you want to sit with yourself. Which one you are not ready, you will do. And I tell you the most important point here, the last talk, the last GTG, the last update, the last record. This is the last message, doctor, I will say for you here. And Ilza, during the session, I remind you by the reduced fetal movement, this one ovarian hyperstimulation, like in sclerosis. Tell me what is what is the update? So it will
Madam,
be, yeah.
Madam, you have to prepare mock exam for us, for all students.
Inshallah, we'll try our best, doctor. I will see Dr. Fath Rahman what he will say, and we'll support you till the exam day. All the best. في أمان الله.
Thank you. شكرا جزيلا.
يلا بالتوفيق يا رب العالمين. في أمان الله.
Thank you.
شكرا.
شكرا.
Thank you.
مع
Thank you.
السلامة.
يلا في أمان الله. Thank you, doctor.